Thursday, September 14th, and we are going to now hold our Healthcare Consumer Access and Affordability Committee. We do have a quorum. Senator Sparks has checked in and had to step out for another meeting, and we also have a couple other senators on the committee that will be in and out during the course of the business. So, are there any specific items of business from any of the members of the committee that you'd like to address? Seeing none, we'll go ahead and ask for our first presenter, Ms. Julie Sonier, the president of Minnesota Community Measurement, and she'll be talking about the total cost of care. Thank you, Ms. Sonier, for joining us, and please identify yourself and begin. Thank you.
Good afternoon, Mr. Chair and members of the committee. My name is Julie Sonier, and I'm president of Minnesota Community Measurement. Thank you for inviting me here today to talk to you about our work that's related to the cost of healthcare. First, it's probably helpful to give you a little bit of background on Minnesota Community Measurement and what we do. We're an independent nonprofit that was formed in 2005 with the goal of accelerating improvement in health and healthcare in Minnesota through measurement and public reporting. The idea was really to establish a clear set of priorities and work collaboratively rather than everyone going about working on different and possibly conflicting improvement goals. Our board of directors includes representation from a range of stakeholder interests, including health plans, physicians, hospitals, employers, consumers, and state government. Our vision is really to be the trusted source for health data and measures to drive change that improves health, patient experience, cost, and equity of care for everyone in Minnesota, to be a resource that's used by providers and patients to improve care, and to partner with others to use our information to catalyze improvements in health. And I would say that last piece is particularly important because as a measurement organization, we aren't the ones that directly drive change. We're just providing a catalyst for it. Over the years, we've built a very robust measurement and reporting system in Minnesota. We started out just measuring healthcare quality, but over time, our work has expanded to include patient experience and cost as well. You might be familiar with the Triple Aim framework that focuses on improvements in three key areas: population health, healthcare cost, and patient care and experience. Our work today spans all three of these dimensions. And then finally, I'd be remiss if I didn't also mention that we've been pioneers in measuring disparities in healthcare by race, ethnicity, language, and country of origin, information that we believe can be used to reduce the sometimes very large gaps in health outcomes that we see here in Minnesota. I'll spend the rest of my time today, though, focusing on the data and analysis that we do that's related to healthcare costs. We collect and publish three different types of information on costs. So the first type is information on total cost of care, which is calculated at the medical group level. This is the average per person cost of care for the entire patient population that's managed by the medical group. It includes all the care that the patients received over the course of the year, regardless of where the care was delivered. So, for example, if the patient was hospitalized during the year, those costs are included in the total cost of care. It's not just the cost of care that was delivered directly and paid for to the medical group. It represents the total amount that was paid for care, so either paid by a health plan or paid by the patient through deductibles and cost sharing. So very important to note that it's not billed charges, so it's actual amounts that were paid for health care. And then finally, this analysis also is risk adjusted to account for the fact that some medical groups have sicker patient populations than others, and we remove outlier expenses over $100,000 for any given patient as well. The second type of cost information that we have, which we published for the first time last fall, is information on the factors that drive variation in the total cost of care. So this is really closely related to the total cost of care analysis, and it uses the same methodology, which I'll talk a little bit more about in a minute. But basically, it breaks down the total cost of care into two components: price and resource use. Resource use is really a term for the amount of care provided. It includes volumes of services as well as differences in the intensity of services. So for example, an MRI has a much higher resource use than an X-ray. And then finally, the third type of cost information that we publish is prices for common healthcare services by medical group. Right now on our website, we publish prices for about 90 common services, such as office visits, imaging procedures, colonoscopies, lab tests, obstetric services, and minor surgical procedures. Later this fall, when we refresh this data, we're going to add about 30 new services to this list. An important thing to note about this price data is that, again, it represents the actual amount that providers get paid for a service, which is not the same as billed charges. So there's a lot of data out there that is about cost, that is billed charges, and we all know that what gets paid is usually a substantial discount off of billed charges. So it's hard to know what to make of billed charges data. So what we've got is actual average payments amounts. What we're publishing is an average across health plans. So for any one person, that might not be the exact price that gets paid, but it serves the purpose of letting consumers, employers, and other purchasers see the variation in prices across different providers. So we publish all of this information in a few different ways. One is that we publish a report each year on the results of the cost analysis. So last year, the report included results for 121 different medical groups in Minnesota. And then because specialty providers are also included in that sort of unit price analysis, we're publishing those prices for about 200 medical groups in total across the state. In addition to the detail by medical group, this report that I'm talking about also includes statewide and regional analysis and analysis by category of service, which I'll share more of in just a minute. But first I wanted to talk a little bit about data and methodology, and I promise I will be brief on this. The data that's used for this analysis is claims data, which we get from the 4 largest commercial health plans in Minnesota: Blue Cross, Health Partners, Medica, and Preferred One. We don't get the actual claims. Instead, how this is done is each of the health plans runs the analysis using the exact same methods, and then they provide summarized data to us in a form that we can combine it across health plans. The analysis includes over 1.5 million people in Minnesota with private health insurance, and total spending for that group is about $8 billion a year. There are actually many more people than that in Minnesota who have private insurance, but the analysis is limited to these people for a couple of different reasons. One, it only focuses on people ages 1 to 64 who had the same health plan for at least 9 months of the year. So if somebody changed jobs and gets insured with a different company, they're not part of the analysis. In addition, the method that assigns patients to healthcare providers is based on which medical group provided the majority of primary care services to that patient during the year. And that method only ends up assigning about 2/3 of patients to medical groups. So it's really important that the assignment process be able to be done with confidence and integrity so that people have confidence in the results. And as a result, some of the data doesn't end up getting included in the analysis. Another reason why somebody might not be included in the analysis is if they didn't use any primary care services during the time period we're looking at. In order for us to report the results of this analysis by medical group name, there have to be at least 600 patients included in the analysis for that medical group. Again, that's a measure that we take to ensure that the results are robust, and using the large enough, if they're based on a small number of people, then there would be questions about how reliable they are. The analytic method that we're using is the Health Partners Total Cost of Care and Resource Use methodology, which was developed here in Minnesota by Health Partners and is currently being used in communities across the country to do analysis like we're doing. The method is endorsed by the National Quality Forum, which is really considered the gold standard for healthcare performance measurement. And then, as I mentioned, the health plans are each running this analysis on their own using this method, and they send us the results. After we combine them, we send providers' own results to them for them to review privately and let us know if they think there are errors in the analysis. After that, we share all the provider-level results so that each provider can see how they compare to others. And there is a review and appeals process before we do any publication of the results. So in addition to that report that we publish, we also disseminate these results in a couple of other ways. So one is that we maintain a consumer-friendly website, mnhealthscores.org, where people can go and sort of type in a location or a medical group that they're interested in and interactively pull up the data that they're interested in. We also provide a much more detailed analytic report that has lots and lots of detail that's available only to the healthcare providers themselves. So it shows how they compare to statewide averages in detailed categories of services such as hospital admissions, emergency room use, outpatient surgery, radiology, and prescription drugs. And the point of this is to sort of try to bring that information down to a level where people can see where there might be some actionable things that they can do to improve results either on resource use or the price side. So now getting into the results that we publish. At a statewide level, we found that the total cost of care for patients with private insurance was about $491 per month in 2016. This was an increase from $435 a month in 2013. The biggest share of spending, almost 44%, was for professional services. So this includes physicians, nurse practitioners, and other clinicians. It also includes lab and radiology services and some prescription drugs that are administered in an office setting. Inpatient hospital services accounted for about 14% of the total cost of care, and I want to make sure to describe that the inpatient hospital is only the hospital's facility fees, and it doesn't include the professional services of physicians that were provided during the visit, because those are in the first bucket that I just talked about. Outpatient hospital services, again, this is just the facility fees that were paid to the hospital, were 24% of the total cost, and prescription drugs were 18%. I think given all the attention that's being paid recently to prescription drug costs, it's important to note that this category, as we're able to analyze it, only includes what we call take-home prescriptions, not the cost of drugs that might be administered and billed for through a setting other than a pharmacy. So, for example, we see lots of increasing use in specialty drugs that are administered by medical professionals in either an office or hospital setting. Those drugs wouldn't appear in the prescription drugs category here. They kind of might appear in any of the other three categories. In terms of growth over time, this next slide shows growth rates for different categories of service. So the set of bars over on the far right of that slide is growth in the total cost of care, which was actually pretty moderate between 2013 and 2016, at least compared to historical averages of about 5 to 6% per year for private insurance. Looking from left to right, I think the first thing to notice is that the cost of inpatient hospital services barely changed at all over this time period. And this is really consistent with more long-term trends of services shifting really from inpatient to outpatient hospital settings. Outpatient hospital services grew at about 5 to 6% per year. And again, some of that probably reflects a shift from inpatient to outpatient settings. Growth in professional services varied over this 3-year time period that we're looking at here, but the total growth over 3 years was about 11%. And then finally, prescription drugs were the fastest growing category overall, with very large increases in 2014 and 15, but slower growth last year. Over on the far right side of this slide, I have a pie chart that shows how the different categories of services contributed to the overall growth. So that growth from $435 a month 3 years ago to $491 today. Because professional services are such a large share of the totals to start with, even though they grew at a modest rate, they do account for about 40% of that total spending growth. And outpatient hospital and pharmacy each accounted for about 30%. One of the main reasons that Minnesota Community Measurement does the total cost of care analysis is to be able to better understand variation in costs across medical groups. And as you can see on the slide that's up on the screen now, there's quite a bit of variation from a low of about $386 per patient per month to a high of $977 per patient per month in 2016. Again, that average was about $491 a month. I mentioned earlier that we also break down the total cost of care into two components, the price and resource use, or relative utilization. And this chart shows how the medical groups in Minnesota break out along those two dimensions. So it might be a little bit hard to see, but if you were, exactly at 1.0 on each of these dimensions, it would mean that you are exactly average in resource use and exactly average in price. So we have many medical groups in the state that are lower price than average and lower resource use than average. It's also possible to have high prices and low utilization, or sort of any combination of those. We also look at the variation by region of the state with some interesting findings. Up until this point, I want to note the data that I've been sharing with you are pretty hot off the presses for our recently completed 2016 analysis. We haven't done that yet for the region, so what I'm about to show you is from the report for 2015 that we published last fall. And in this chart, a number above 0 means that the region was above the statewide average, and a number below 0 means that it was below the statewide average. The bluish-gray bars represent the total cost of care. Red is resource use, and green is price. So in the central region, for example, which is the far left side of the chart, the total costs were 1% above the statewide average, and that was a combination of having resource use that was 4% below the statewide average and prices that were 5% higher. The southeast region as a whole was similar to the state in resource use, but had much higher prices than average. We also see some regional variation. So this is the total cost of care. We see some regional variation in sort of those service categories that make up the total cost of care. So, for example, both inpatient and outpatient hospital services, the use of those services tends to be higher outside of the Twin Cities metro area, and that might be sort of kind of because of the infrastructure. There's less availability of alternatives outside the metro area. While the metro area sees slightly higher costs, both use and prices for prescription drugs. So before I wrap up, I wanted to show an illustration of some of our data on variation in the unit prices for specific services. So this chart sort of just gives some examples of some of the service, the price data that we have on our website. So for example, the cost of a knee x-ray for a patient with private insurance ranged from about $20 to $219 in 2015, which is a more than tenfold difference depending on which medical group provided that service. The cost of a strep test ranged from $8 to $101, and a 15-minute office visit cost anywhere from $75 to $210. Remember, these are actual payments, not billed charges. And over on the far right-hand side of that chart, we put in the fee schedules for Medicare and Medicaid as a comparison, which are almost always substantially lower than the prices that are paid by private insurance. There's one additional point that I thought would be important to make about this unit price data, and is that a lot of times when people talk about cost transparency, what we're really talking about is prices for individual services, and that's clearly important, especially for consumers who face increasingly higher deductibles and out-of-pocket costs. I think it's also important to remember that the total cost of care is heavily influenced not just by prices, but by the amount and types of care that people are using. So if we were to focus on prices alone, we'd be missing a huge share of the variation in total cost. So just in closing, there are a few key points that I wanted to leave you with. One of those is that for people with private insurance, there's currently a 2.5-fold variation across medical groups in Minnesota in the total cost of care. And that's due to some large variations in both resource use and prices. With regard to the drivers of cost growth, pharmacy and outpatient services are growing at the fastest rates over the past 3 years, but professional services are the largest share of spending, and because of that account for about 40% of the total growth in the cost of care. And then finally, you can't improve what you don't measure. Producing and publishing comparative information on cost has really focused attention on the variation that we see in our healthcare market and provides a tool for identifying improvement opportunities. Mr. Chair and members of the committee, thank you for your time today, and thank you for inviting me to speak about this work.
Thank you very much, Ms. Sonier. Your presentation was cogent and succinct, and I appreciate it. Are there questions from the committee? Senator Klein.
Mr. Chair, I appreciate that you're just laying out the facts and not going into, I guess, analysis of them as much, but can you speculate on the factors that drive up costs in southeast Minnesota compared to other regions?
Ms. Sonier?
Mr. Chair and Senator Klein, so we're able to tell from our analysis that, a fair amount of it is due to price, and I will say that our observation is that prices are higher in general in that region. It is not one specific provider that has higher prices, but, there's something about that part of the market where prices are higher. Where I've been able to see data otherwise, it appears that the same thing is true sort of across the border in Wisconsin. So it's just a sort of a regional variation where, for some reason, prices are higher than average.
Senator Klein? Senator Drahan? Ms. Sonier, I have a couple of questions. The cost data that Minnesota Community Measurement is coming up with is, I see a fair amount of the data. In fact, I brought the report that we have from the clinic I work at Catalyst Medical Clinic. And this is, I would say that your organization over the last 12 years has grown, and I think you're, if you will, you're hitting your stride. You've helped many clinics enhance the quality of care, the consistency of care, whether you're talking about recommendations for colonoscopy or improvement in asthma protocols or diabetes. You've turned your attention to cost of care, and that's clearly an issue for this committee and for the entire legislature and the entire state. Do you have any thoughts as to how this information can best be used to bend that cost curve? I mean, we have variation across the board on, like you said, the strep screen's $8, $24, $100. If you were king for a day or a queen for a day, what might you think about doing to try to lower the cost of what overall Minnesota's paying for health care? If you would, please. Thank you.
Mr. Chair, thank you for the question. I'll give you two suggestions. One of those is that this information has the potential to be used by employers and other healthcare purchasers to design benefits that give people stronger incentives to consider cost and quality when they're choosing a provider. And some of you might know that I used to direct the state employee group insurance program, which has a benefit design that does exactly that. And in my view, that's been very effective over time in encouraging people to take into account that variation in cost when they're choosing a provider. So that's one thing. The other one is that from a health plan or private payer perspective, one of the things that we increasingly see is taking into account this information when contracting with providers. So, for many, many years, we've had a system that is, the fee-for-service system that simply pays on volume of services. And it's pretty clear that that's not getting us where we'd like to be in terms of the state as a whole, in terms of maintaining affordability of care, and that we need to try some different things. So some of the newer contracting methods, what's commonly called value-based purchasing, take that information into account in trying to get the right incentives into contracting for cost control. So it's either rewarding providers that are more efficient and lower cost than others, or setting up some kind of incentives around cost containment and quality improvement, instead of just having a contract that pays for volume of services as they're provided.
Thank you, Ms. Sonier. Any other questions? Seeing none, thank you very much. Appreciate it. We will move on to our next presenter, and that will be Mr. Tim Rice and Ms. Teresa Fisher from the Lakewood Health System. Thank you very much for joining us. It's a pleasure to have you. If you'd please get things settled, and Bailey will help you get the technology worked out, and then we'll have you introduce yourself and go ahead and begin. And again, welcome.
Mr. Chair, I'm Tim Rice. I'm President and CEO of Lakewood Health System in Staples, and it's a pleasure for us to be here. I'll have Teresa introduce herself.
Good afternoon, Mr. Chair and members of the committee. I'm Teresa Fisher. I'm the COO and CNO of Lakewood Health System.
So again, we're just appreciate the opportunity just to present, opportunity to share, our story from a rural community. As far as, I'm going to start out just with a quick overview about Lakewood to give you an idea about the organization. Very quick on myself, I've been a CEO for 40 years, of which 37 of those years have been at Lakewood. And yesterday at this time, I was fishing in Lake of the Woods, so this is quite a contrast from yesterday from where I was at. So just very quickly about Lakewood. We're located in Staples, Minnesota, which is in the center part of the state, and we've grown to be one of the largest independent rural health systems in Minnesota. We started out as a city hospital, and now we offer a full continuum of clinic, hospital, and senior services. The senior services consist of a 100-bed care center, senior housing, assisted living, and we serve about a 50-mile radius. We merged with physicians in 1997. We're one of the first to do that, to become a fully integrated private nonprofit system. And really the exciting part about that is it really allowed us to focus on the needs of our patients and residents. We didn't have to be concerned about, well, what parts does the hospital do, what part does the clinic do, but ever since that in 97, we've had the opportunity for us to be on that full continuum state. Every day it's, well, what's best for our patients and residents, and be able to focus on that. And out of that, we were one of the first to become certified for medical home, and again, led by one of our physicians. Also, one of our physicians leads the state for rural palliative care and leads a number of those initiatives. But again, being independent and being really, we're provider-led, physician-led, with very collaborative, administrative, and very a board relationship and great employees. Again, our energies are really focused on our patients and our residents, and really what are the changing needs of the communities that we serve. We also have dyad physicians, so each administrative individual in the system has a physician partner, which has really been helpful in us in making our decisions for organization. Our most recent efforts have focused on accountable care organization work, IHP involvement, care coordination, data management to achieve the triple aim. We've been doing a lot of work on community health to address key social determinants of health, primarily on food insecurity. In fact, our whole county is identified as food insecure. But primarily, we've continued to invest in what's right for our community, what's right for our patients. At the same time, we've continued to meet our financial goals. Through all this time and investments, we've had the ability to tax and have never taxed in our history as an organization. So we've been very proud of that. If you take a look at the screen, I think it gives you a quick overview of really the area that we live in. Again, we have 5 primary clinics in the area, but our counties are some of the poorest in the state, classified as economically distressed. We're in a health professional shortage area, medically underserved, and we have a huge majority of Medicare and Medicaid, and our Medicaid level is probably about twice the market average. So if you take a look quickly before we get into the more specifics of what we've been doing, what have been the factors for our success? I think one of the key things has just been our whole focus to remain independent. It allows us to make decisions quickly and then focusing on really who we're here to serve, and that's our patients and residents. We've really been focusing a lot on trying to keep high quality care rural and local. Accessibility is a big issue. Transportation is an issue. But how do we recruit family practice and specialists to be available for our local community? And really a key part of our success has been our physicians. And they really desire to work at Lakewood because we're independent. They like to seek out an environment where they have an opportunity to have control over their practice, to have a voice. And that's been a key element in our recruitment and retention in our organization. It's also allowed then innovation and willingness to try things to occur. And out of that come too is a real focus on partnerships and relationships. We work closely with like Essentia and Centricare on opioid reduction, transitions of care, community health, EPIC, ACOs. For 30 years, we have been meeting with the area hospitals in Todd, Wadena, Morrison County, have been meeting every quarter and with public health, focusing on maternal child health and community health, but we've been doing that for 30 years. And then the other thing, our collaboration, we work in our local community. One of the big issues we're experiencing right now is food insecurity for children. And the schools have identified, for example, a number of children who do not have enough food for the weekend. We work with the school, and then we have food delivered to backpacks for those children, so that, because we know the school's identified, I think it's up to 50 children who would not have enough food for the weekend, and we work with the schools on that. So basically, the factors to our success is we try to do what's right for our patients and residents, and we have the structure and culture that's what we focus on. And I'll have Teresa now just share, because of all our factors and structure of what we've been doing to bend the cost curve.
Thank you, Mr. Russ. Thank you, Mr. Rice. Ms. Fisher? I see that you've got quite a few slides, and if I could just ask you to try to devote a good share of your time to the cost of care and bending the cost curve down, and from your perspective, what prevents you from being able to reach your goals in regards to what the system puts out there? Thank you.
Mr. Chair, members of the committee, so I'll just spend a few minutes just talking about what we are doing to bend that cost curve. We have invested tremendous amounts of dollars into doing what Tim mentioned as the right thing for our patients. You know, we are very committed to our community and know that there are underserved patients in our community that can't afford a lot of, everything from food to their health care. So we've made investments when other rural health care organizations have not, and we could have stepped back and said, no, do we really want to make those investments? Becoming the first medical home, being invested in care coordination. It's very expensive. It's very resource intense. As a nurse by background, it takes a lot of resources to support our providers to do those right things. There's a lot, as many of you know, the work that's coming to these providers and our physicians, from charting to EHRs to all kinds of things, which Tim is going to get into a lot of those obstacles and the things that we really do just need to have changed in order to sustain some of this good work. But first, let me talk to you a little bit about some of the things that we have done. In particular, expanding access to care. When we looked at total cost of care, we knew that we had some really high utilizers of our care. In diving into some of that data, we did address several areas, ED and inpatient being the first two areas that we needed to tackle. The emergency room was a big one. Rural healthcare, it would be very easy for us to just say, let's just, people come to the ER when they're sick, after hours, weekends, holidays. We didn't do that. We invested in online appointments, expanded our urgent cares, expanded same days, made these investments so that patient costs can come down. Our care coordination also helps our patients get directed into the right place, the right care areas, and that it does come at a cost to our system, but again, it's the right thing to do. We want to keep those patients out of the ER as much as possible, and I will just share, we made an investment into community paramedics. We did that intentionally. As we looked at patients who were utilizing our ER over and over and over again, we saw simple needs of these patients that, some of them just couldn't get their medication straight. So we sent out resources. We took our medical teams to them and helped them organize their meds and do some, to keep them out of the ER. We've also made investments in community health, as Tim mentioned. We're doing the right things because our patients expect us to do that. But again, that definitely comes at a cost. And I'm going to let Tim walk through the obstacles and the things that we need to do to change this so that we can continue to sustain these improvements in the health of our community, as well as reducing the cost to them.
So, Mr. Chair, I think the main obstacles we've been running into is just decreasing reimbursement. For example, right now, some of our Medicaid is less than our costs, but I think if our reimbursement keeps dropping, at a certain point, we're not going to be able to maintain investments to do what's right for patients. So a key thing is decreasing reimbursement for rural facilities. I think the second one is that there's just a lot of requirements for our physicians. And if they have a lot of things they're required to do that take them away from their patients, it's not that they're not desiring to work and to gather data, but if there is a lot of unnecessary things they got to do in their work and recording, I mean, even this morning, we had a physician meeting, and they talked extensively about, there's certain things that they have to do, but if they take time, they're saying, what's more important? Is my patient more important, or getting some of these done of which they don't say is value? And we had a great discussion on that this morning. And, they're concerned about that they focus on the right things. Just economies of scale, just a rural facility, we're just really vulnerable. If there's major changes or shifts of costs or risks, we just don't have the volume because being smaller to work our way through that. The other is it's not a level playing field. I think just to really identify the concerns of a rural area. We have like double the Medicaid compared to other facilities. I think a key thing, we don't have rural broadband. For many, I mean, we want to have our board members to have rural broadband for a board portal. 3 of them don't have access to internet. But how are we supposed to, we're trying to recruit physicians, but their spouse may have a work, but they're saying, I can't come there because I can't run a business out there. I mean, how are we supposed to address that? We have issues of transportation, again, the professional and worker shortages, just the fact of the economic aspect of a rural community. We are the economic base, unfortunately, compared to other businesses, and so to me, those are the key obstacles that we're facing. And if we wanted to get into how we can help, just to make sure we keep this succinct, I think for us in rural, it gets really down to the basics. We can't work on what's right for patients if we do not have rural physicians and, addressing rural healthcare work shortages. I mean, our whole basis is you got to have the people to do the work. And if we don't have rural broadband, how do we effectively work? Now, a couple of great examples is a lot of our patients in addressing their healthcare needs address mental health. We have a number of mental health providers on the clinic side, but the reimbursement isn't there for us to maintain or even address those needs. But assistance in addressing reimbursement for clinic mental health would be critical. And then on palliative care for end of life, a lot of costs are at end of life. We have a great palliative care program, but it's not reimbursed, and all that cost is being absorbed by us. But we know that it's keeping a lot of patients out of the hospital, getting care in the home, and saving significant money. And I think the main thing is just recognizing that rural healthcare really does have a place and a role in helping decrease unnecessary healthcare spending. So thank you very much.
Thank you, Mr. Rice, and thank you, Ms. Fisher. Are there any questions from the committee? Senator Friends.
Thank you very much, Mr. Chairman. And thanks very much for the presentation. It's got a lot of highlights and a lot of good news, and this is a committee that welcomes good news. My question has to do with your recruitment and retention success, which we can see, and that's great. And I guess the question would be, if you had to identify a reason other rural clinics and hospitals and systems have not had as much success, what's the one thing you'd say to them that would boost them?
Mr. Chair, Senator Friends, the key thing has been our physicians have really been active in teaching. We have medical students in all areas, all over our organization all the time. And our physicians just are so active in that area. And what it does, it creates exposure to our organization. And that's been the main part of our recruitment. They get to see our organization, and that word gets out. And so I think it's because of our physicians is why we've been successful.
Thank you, Mr. Rice. Senator Rosen.
Thank you, Mr. Chair. And Mr. Rice, it sounds like you have the kind of care that we all wish we had. And you're using all the tools that have been provided to you, especially from here at the Capitol. And that's been wonderful. And that you were the first to use the medical home. That's great, the care coordination. I'm going to just take in a different area. I know mental health is a huge issue, but are you addressing, and how are you addressing the dental issue also, which is huge also?
Mr. Rice, Ms. Fisher, please feel free.
Mr. Chair and Senator Rosen, dental. So we have partnered, we have a full-time dentist at our organization who has, I think, and that's Dr. Daniel Rose, for many of you may know him, but he definitely has taken on the entire state's dental population, for those uninsured. I mean, he is very committed to, his personal mission of taking care of these patients who can't get care elsewhere. And we are trying very actively to figure out ways to integrate dental into primary care. We do run up against constraints, to be perfectly honest. Rural health care clinics, which we are designated, our 5 clinics are rural health care. Dentists are not eligible providers in the rural setting. That is the biggest problem. So we cannot operate dental clinics or even care for patients outside of the OR for their dental needs without legislative changes there on that front. So that is an obstacle. We try our best to work around as much as we can and get patients in and be seen. A lot of it pro bono work that we invest in our dental program. We are committed as a health system to having a dentist on staff and to helping these patients.
Thank you, Ms. Fisher. Other questions? I have a couple of questions. Mr. Rice, you mentioned several obstacles. You said the MA fees don't meet your costs. The electronic health record has a cost to it, as well as a time demand and probably a drop-off in physician productivity in terms of how many patients can be seen in a given day. Outstate Minnesota with its broadband challenges as well. Economies of scale in greater Minnesota are certainly not going to come into play as much as in a metropolitan area. And then lastly, the fees that are being reimbursed for mental health services. And we've even just recently seen one of the major carriers drop theirs substantially through the use of an intermediary. Somehow we need to attend to your needs, because you're an unusual success story for greater Minnesota in that you've been able to, if you will, continue to pursue and achieve your mission, but there are many, many clinics and physicians in greater Minnesota that don't have that situation. I've asked this question before, and I'll ask it again. If you were the decision maker for a day or for a week or for a month, and you could put into play those things that you thought would both allow greater Minnesota physicians and clinics and hospitals to do a better job of caring for its people, and at the same time bending the cost curve downwards, what types of things would you do?
That is a big question. I think one is that we would take a look at reimbursement. Would definitely be one area. I think equity of fee schedules, and I think we have to recognize, that as far as equity for rural, for example, we know that different cost indexes and other things we're being compared to, may be set at a metro, maybe set by metro, but it doesn't always represent all the factors that may come into rural. So I think it's just taking a look that we want to do our part, but I would just try to take into consideration all those factors that come into rural, whether it be working with plans and reimbursement, taking a look at regulations and requirements, specifically in the area of if there's all this different time and requirements, you take a look for our physicians. One of the big things they brought up this morning, they said a lot of the rules and regulations fit for physicians who work in one area. But our physicians will work in the ER, then they go up to be the hospitals, then they run over to the clinic. And then they also are taking care of the care center. And then they're saying, so it's just that all the different rules and guidelines and fees just don't all fit one specific situation. So if I would do is I would try to take a look at all of the elements of payment, regulations, and rules to make sure they're appropriately fitting, for example, the situations that we experience out in our rural Minnesota.
Thank you, Mr. Rice. You've been involved in healthcare a long time. You may have heard information being provided by Ms. Julie Sonier a few minutes ago. Is there any way in your mind that you can justify a strep test of $8 and an office call of $75 in one place in Minnesota, and then that same strep test, $101 instead of $8, and that same office call instead of $75, $210? How do you get your arms around that as a clinic administrator trying to believe that we in the legislature try to create a level playing field and try to honestly address the inequities in the system.
Mr. Chair, one of the things that we are, as a healthcare organization, we are not allowed to compare prices. So it's not legal to do so. So we do not know what the comparative prices are for different things. Now, maybe there's different ways of getting it, but we cannot call, our neighbors and saying, what do you charge for this or that? So what helps us is that patients will call us. I think they're our biggest resource. And so we try to take a look at that. So, so I think one of the things is we don't know. The other thing is that you're trying to divide up there's no consistent way of where you set your charges. Some can be, really low on ancillary and make their room rate a lot higher. So there's so many different areas in which you can place charges. There is a lot of variations that can occur. So I think the other is, for example, we've never taxed. You can have organizations that maybe, for example, if you're comparing us to a place that would get $1 million in tax subsidy, but then all of a sudden you're comparing their lab price to my lab price, but I don't take the $1 million, that makes it, more challenging too. But I do think, that another situation for us is we don't always know what competitors are doing, but to try to impact, we have not raised our rates for 3 years. We've not raised our charges. But just from the overall standpoint, we know that we want to try to keep our costs down. So I definitely would say, if you looked at us, we have some prices that are higher. But if we find some that are not, we do work to try to get them lower and then manage the costs accordingly. So I would say other information that help us to know how we're comparing, just as was showing up, we do use that. So it is really helpful to us to know, where some of our comparisons are, but having access to that information would be helpful.
Thank you, Mr. Rice. I think your comments underscore the importance of the work that Minnesota Community Measurements is now doing in regards to total cost of care. This is, for clinic administrators and physicians, one of the first times we're actually getting a look, because we're always hamstrung by the fact that we can't ask our neighbors or try to find out what the costs are. I want to comment on one thing in regards to your care management. And a recent article on end-of-life care came out, and it indicated that half of Medicare patients in their last month of life, half will go to an emergency department, a third will be admitted to the ICU, and a fifth will have surgery, even though 80% of them say they hope to avoid hospitalization and intensive care at the end of their lives. One of the best ways to avoid those things is to be in touch with them, coordinate care, go to their homes, do whatever we can to make sure that the way they have indicated they would like end-of-life services to be given are indeed taking place. I want to say again, thank you for coming, and we hope you stay in touch with us. We need answers, and we really do want to bend the cost curve. It's greater Minnesota clinics like yours that are dealing with the challenges that will provide guidance for us as we deal both with the metropolitan areas and their challenges, as well as the greater Minnesota areas and their challenges. Are there any other questions? Now, one last question I have for you, because Senator Pratt raised this last week. How do you go about in your organization specifically identifying what you consider to be perhaps an excessive ordering of low-value services so that you can get at that and possibly try to reduce the incidence of those low-value services? Have you had to address that challenge in your organization, perhaps in regards to MRIs or CAT scans, any of these kinds of things? Do you have any thoughts in that regard? That just came to me at the end. Thank you.
Do you have some of that with care coordination?
Mr. Chair.
Please go ahead, Ms. Fisher.
So we look at all of our data that comes in. We have one example comes to mind is MRI utilization in the ED. We did see that we had some of that going on, and I think, we had to take that to our physicians and say, when would this really be appropriate? Let's follow, evidence-based care guidelines, and is that really something we should be running in the ED? Just because we have an MRI doesn't mean we need to be doing that during that type of a visit. So we actually did partner with our physicians and reduced MRI utilization. I don't think in the last year we've had maybe even one. So we bring it to the physicians, and once they have the data, they're great. We do a lot of partnering with our physicians. So if we have that information, we take it to them, and our size is convenient in that we are pretty nimble. We can make policy changes very quickly. We have physicians at every single administrative table, and so we can change protocols or policies as needed. So we do the work with them.
Thank you, Ms. Fisher. Senator Rosen.
Thank you, Mr. Chair. And Mr. Rice or Ms. Fisher, tell us how telemedicine is working for you. I think that's extremely critical on the retention of our physicians, the ability to provide the care coordination to our patients, and what can we do to make it better for you for telemedicine as far as reimbursement or whatever?
Mr. Chair and Senator Rosen, we are just talking about telemedicine today because we are underway a huge project around telemedicine. We launched our stroke prevention program in our ED, so we have had that now for about a year. Many success stories out of that of patients who would not have had the outcomes that they have today. I could share many stories about that, and it's just fantastic for our community and our patients. We also have expanded telehealth into the clinic about a month ago for the post-stroke patient. So we work with Centricare on that, but we're also underway with Children's to bring pediatric care and subspecialty care to central Minnesota, which we're really excited about expanding that. We do utilize telehealth for our home care patients as well. We've had for many years now patients with iPads and all kinds of technology to interact with physicians. I guess the barrier that we run into is the reimbursement. I mean, all these things are the right things to do, but we don't get paid to do them. Face-to-face visit requirements are tough for us. We have many times where we'd love to have a PA or an NP who could do those calls, kind of maintain or sustain that care for the patient through care coordination, but that's not reimbursed. So those are some things that I think as we expand telehealth and the coverage, for our rural health community that we'd love to invest more in that, but we're faced administratively with take a physician out of a clinic, if they can see 13, 15, 16 patients a day and have them see a medical home patient or a home care patient in their home and not get reimbursed, that's a difficult decision. Right thing to do, but we also have to, meet our bottom line as well. So.
Thank you, Ms. Fisher. Senator Rosen.
Thank you, Mr. Chair. And Ms. Fisher, we've worked very hard at the legislature on that issue, and I think we've made great strides. I'm going to take a look at that legislation from last year because we are reimbursing the interaction face-to-face better, equalization better. But I promise you we will continue to work on that because that is a very important tool in your toolbox to make sure that you are successful and you can stay and keep your doors open.
Thank you, Senator Rosen, and thank you again, Ms. Fisher and Mr. Rice. We so much appreciate your coming. Thank you.
Yeah. Mr. Chair, Senators, thank you very much.
Thank you. Next, we will be having two presenters, Mr. Stephen Schondelmeyer, a PhD in PharmD, and Mr. Rick Smith. What I would like to do is I'd like to have Dr. Schondelmeyer present for 15 minutes, and then I'd like to have Mr. Smith present for 15 minutes, and then I'd like to have both of them at the table so that we can have a little bit of a discussion with potentially counterpoint, as one represents the academic world of pharmacology and the other represents the commercial industrial world and scientific world of pharmaceuticals. So if we could have Dr. Stephen Schondelmeyer come to the podium, introduce himself, and begin. Thank you so much.
We could go to the end, but yeah.
Oh, do you have to jump back?
No, it's not.
No problem.
Yeah. Thank you, Senator Jensen, and thank you, committee members. Again, I appreciate, and we as citizens of Minnesota appreciate your continued examination of this issue. Healthcare is important to all of us. As you might recall, I presented previously to this committee, and we had lots of good discussion, but didn't get down to the solutions. What can you do about it into the world? On the one hand, there are a lot of complex issues that lead up to and shape what solutions might be available. On the other hand, there aren't any silver bullets or easy solutions either. I've examined the types of solutions that are being proposed by various states and by various governments and other places out there. And I'll talk briefly about some of those and suggest some that maybe Minnesota might consider. And I will tell you, I haven't thoroughly examined all of the state actions that are out there. Just from National Academy of State Health Policy, there's a list of probably at least 100 bills that have been active in the last year related to pharmaceuticals and pricing and things that various people think might bend the curve. Among the issues that are proposed are transparency. And I'll talk through the issues. I'll kind of present a topic and variations on the theme that are proposed, and then some comments about what might work or might not work. There are a lot of issues around transparency that are triggered by various measures of when a price for a drug changes by a certain amount over a certain period of time. Some of the bills say by 50% over 5 years, by 15% in 1 year, by 100% in overnight. There are a lot of different triggers or measures. And these proposals then say if a drug, like we saw with Daraprim and Martin Shkreli, or like we saw with the EpiPen, or like we've seen with naloxone now has jumped dramatically. So people propose after a drug meets a certain trigger, then there should be some type of accountability or transparency. And what they suggest is they'll give a laundry list of financial data that a drug company should submit to the state. It includes the cost of production, the cost of research and development, cost of marketing and advertising, cost of other administration, cost of rebates, and they go down a laundry list of things that should be reported. Often they say, who do you report it to? It's often the Commissioner of Insurance or other parties within various state health departments as the recipient. Often they say the information should remain proprietary and confidential, which means that only somebody in a state office building is going to sit and look at it. It isn't something that's actionable by others. There may be a penalty for not submitting it. The penalties are often on the order of $10,000 per incident or civil penalties. And while that's to most individuals, $10,000 would be substantial for a major drug product, blockbuster in the market. That's pretty inconsequential. I would comment also from watching drug pricing practices over the last 3 or 4 decades and watching various state and federal legislative bodies call drug company executives before them to justify pricing. Those do provide interesting hearings. Interesting discussions, but rarely do the drug companies change their behavior based on shaming and blaming. Rarely has it really changed the bending the curve that you all keep talking about. So in general, these practices don't just asking that somebody in the state or in the government receive information and look at it, it really hasn't been very effective. And I think we can go a different direction with that, though. And we can say, remember we talked last time that drugs really, we award, through our regulatory process, we award monopolies to brand name drugs when they come to the marketplace. So we provide patents, we provide monopolies, and we know from other parts of our economy, when you have a monopoly-based marketplace, that the pricing structure requires different types of behavior and oversight in order to make sure resources are used and allocated wisely. Typically what we see is a public good phenomenon, and we see, for example, utility rate regulation, such as cable TV, your electricity, your water bill. Often we award monopolies in these areas, and there's a rate regulatory commission that the various providers or vendors in the market have to go before that commission, justify their prices, and that commission has on it staff and commission members that are experienced in evaluating this information and can do something about it. I think certainly one could regulate the actual prices of drugs, but I think short of that, one could regulate and create a price accountability commission. And what you would want to do is set some trigger points in the marketplace that if prices, at least in terms of their initial price, exceed a certain threshold, or if prices over time after the initial pricing exceed increases at a certain threshold, then that would trigger rate accountability review. And that rate accountability review can then collect the information in a way that is comparable, is easier for someone who knows what they're doing to understand. I still think in order for that to work, you need a leverage, some kind of leverage at the end, more than a $10,000 civil penalty for not reporting it. I've contemplated various things that could be applied. One I would propose, remember we talked also last time about states have established a number of mandatory coverage categories for drugs, or protected categories. We require coverage of mental health drugs. We require coverage of cancer drugs. We require coverage of epileptic drugs. In fact, you may want to set, if the state sets a mandatory coverage of a drug class, that automatically puts those drugs into an accountability format. If we're going to give an even stronger monopoly, not just a patent, but require that they be covered in the marketplace. So we've established you can sell the product in the market. We require all insurers and payers to cover it and include it in their health benefit plan, and yet we don't set any review of the price. We've essentially given a blank check to the seller of that product. So one could argue then we should have a process to monitor how much is that blank check worth, how much should be charged for that, and require. And so one leverage would be if an agreement is not reached by that rate review commission with the drug company, then you could eliminate not all drugs in that class, but that drug, you could say this drug does not have to be covered on a mandatory basis. It could still be purchased. The drug company can still sell it for whatever price they want in the market. Consumers are welcome to pay full cash price if they want. Now, the exception or challenge is if you have drugs that are unique and the only drug available for a process and you really don't have any alternatives. Then you would have to maybe come up with an arbitration process or some kind of process for establishing the price at the end of the day if you don't feel, as a matter of public health, you can withdraw mandatory coverage. Now, the mandatory coverage could be eliminated from Medicaid, could be eliminated from the essential health benefit package in various states. It could be eliminated, or you could tell that employers and payers of health plans in the state that you will be held harmless for not covering this drug. Some employers have a fear that if they don't cover a certain drug, they'll be sued by their employee population or their covered beneficiary population and asked to pay for the cost of that drug, and they're worried about that. That drives coverage sometimes. So one leverage you have is changing the coverage or eliminating mandatory coverage in the marketplace through this rate accountability commission. A number of states had pieces of legislation that touched on this around the country. Nevada's done this. We've seen them in New York, Massachusetts. Nevada has passed something. I haven't seen too many others that have passed them yet, but there are a number of states that have proposed these provisions, and we could learn from those. So that's one option, is a rate accountability process. And we could go through a process. I can tell you in Minnesota, there are a lot of drugs that have had more than 100% increase in a 3-year period or a 1-year period. And some, we need to find out why have they gone up that much and what justifies that. So that's the issue of transparency. There are other issues. For example, a lot of people are focusing on out-of-pocket costs, and certainly out-of-pocket costs to the consumer are important and critical. I think the amount consumers pay out-of-pocket is relevant and worth looking at, but out-of-pocket costs for a prescription drug isn't the cost of the prescription drug. And it shouldn't be the way we measure the cost of that prescription drug to either the patient or society. The reason I say that is I would remind us that the premium that pays for that insurance benefit plan is also an out-of-pocket cost. It's just at a different time that you pay that versus when you get the drug. And so if we have programs that have $0 or $5 out-of-pocket costs for a drug, but they're using $500 drugs versus a $40 drug that's equivalent or identical or even safer or more effective, we're really wasting resources in the healthcare system, and we're wasting an opportunity to bend that curve downward again. So approaches that focus only on out-of-pocket costs, I think, are very short-sighted, and we need to be cautious with those. One example where we can address that is a number of manufacturers offer various patient assistance programs for their drugs or copay assistance, but in particular, there's a category of copay coupons. There are more than 400 brand-name drugs that have exact FDA-approved generic equivalents, and the coupon, though, reduces for any person in an employer-based program that has a copay for a generic drug. They can get that copay reduced from $10 or $30 down to $0, and they can get the brand-name drug. The brand-name drug, on average, may cost $500 or $600. The generic costs $400. It's an exact generic equivalent that the FDA has reviewed, and so these copay coupons induce the patient to use a drug that costs 10 or 12 times as much. It raises the cost experience of that employer, which results in a higher premium the next year, but it's sold on, look, we reduced the out-of-pocket costs to the consumer. I think it's worth contemplating outlawing these copay coupons for brand name drugs that have exact generic equivalents. To make that point even finer, these copay coupons have been reviewed by the Office of the Inspector General of HHS in Washington, and they've been declared as kickbacks and inappropriate inducements to engage in a perverse economic behavior, and they're outlawed under Medicare and Medicaid programs. They're prohibited. If they're inappropriate for Medicare and Medicaid to be paying 10 and 12 times as much, why do we allow this in our commercial marketplace? Why do we let these copay coupons, these inappropriate inducements, take place? So some contemplation of copay coupons particularly, I would initially focus it very narrowly on brand name drugs that have exact generic equivalents in the marketplace. And then once you get some experience with that, we might contemplate other inducements and other types of copay coupons that really have perverse economic behaviors in the marketplace. Another area to consider is there are times when a pharmacy benefit manager will tell a pharmacist, well, let me back up. A patient comes into a pharmacist and asks, I want to get this prescription filled, here's my insurance card. So the pharmacist looks up the insurance program, enters the prescription, and it comes back and says, that'll be a $20 copay. And then the pharmacist knows in their own mind, this prescription only costs $8. Well, most pharmacists would just tell the patient, if you just pay cash, this is $8 instead of $20. There are pharmacy benefit managers today who put in their contracts that the pharmacist can't tell the patient that that drug costs less if they paid cash. They prohibit them from telling it. And in fact, there are some that require that they charge the patient the $20 instead of the $8. What's wrong with this model? So I think we need to look at behaviors where health providers, in this case pharmacists, are aware of a lower cost alternative, and they're prohibited from telling the patient about that lower cost alternative. That doesn't serve the patient, it doesn't serve the employer. So there are some behaviors like this that need to be examined and corrected in the marketplace. Also, pharmacy benefit managers are very important to our pharmaceutical distribution system. They play many critical and important roles. But this is a type of business entity that has come to be a major player in the marketplace, yet there is no regulatory oversight of their functions and their business practices like we have with insurance programs or health plans in the marketplace. Some states have proposed requiring first that pharmacy benefit managers register with the state insurance commissioner, and that the state insurance commissioners promulgate rules and regulations for oversight of the business practices to prohibit things like I just described, where the pharmacist is told, you can't tell the patient that a lower cost medication is available, and we don't want you to engage in those behaviors. Or there are other cases where pharmacy benefit manager may have a preferred network, and they actually charge the employer more for prescriptions under the preferred network than they would charge at the retail pharmacies in the community. Or where they have a mail order pharmacy. Sometimes mail order saves money, but not always. I can show you plans where the mail order costs more than the retail pharmacy, and yet they may have a mandatory mail order. So they require patients to go to the mail order that actually costs more rather than less, and people just assume that mail order is cheaper. That's not always a good assumption. Again, I like the bipartisan advice of Reagan and Truman, trust and verify. It's fine to trust and assume the market will work, but we need to be looking. The last thing I would tell you is Minnesota already has a very valuable tool that I think you need to encourage and open up even further. You have the Minnesota All-Payer Claims Database. This is a database that collects transaction data on health and medical and pharmacy claims that occur in the state. It's the database that's the basis for much of the community measures reports that are done. And community measures, I compliment them on the good work they do. I think we need to begin doing community measures type reporting on the pharmaceutical side of the business and use that information to look at patterns. There are cases where the same drug from a medical practice may cost, as they were reporting, 2 times as much and even 10 times as much for the same drug. And these are drugs that may cost $20,000 on average, and for some other players it may be $80,000 to $100,000 for that same exact drug. So there's wide variation. And then we could also track the differences in various regions of the state. We can track differences across various types of pharmacies, mail order versus community chain pharmacies or community independent pharmacies, and report pricing variations and differences in the marketplace. The data is already there, but we need to make that data more accessible and usable in the Minnesota All-Payer Claims Database. It's an excellent database and has a lot of potential to do community measures type things in the pharmaceutical space.
Thank you, Dr. Schondelmeyer, very much. We've come to the end of our time for your specific presentation, but if you'd be willing, in about 15 to 17 minutes, we'll have you come back, and we'd like to be able to have a little bit of a point-counterpoint. Thank you very much, Dr. Schondelmeyer.
I'd be glad to do that. Thank you. Next,
we will turn to Mr. Rick Smith, Principal, RIS Consulting, on behalf of Pharmaceutical Research and Manufacturers America. Welcome, and thank you for coming, sir. If you'd please introduce yourself and go ahead and begin. Thank you.
Certainly. Mr. Chair, I am Richard I. Smith, representing Pharma. Thank you very much to you and to the committee for inviting us to attend today. While my slides are coming up, I'll just note that in light of the fact that we'll have the opportunity for the point-counterpoint later, I'll just walk through my presentation around the context for pharmaceutical costs.
Thank you very much, sir. Appreciate it. And you can begin when you're ready.
All right. So,
excuse me, sir. I also want to mention that because the previous presenter was over about 2.5 minutes, if you need 2.5 extra minutes, you have it. Thank you.
Thank you very much. So I'll note that this is an extremely exciting time to be working with biopharma research companies. There are just extraordinary opportunities out there, and they're being realized, and we're seeing them come to fruition now. As people think about what is coming to fruition and what's and the opportunities that are now evident for the future, they ask about cost, and I want to address that today. So, next slide, please. Next slide. Okay. So this slide shows the rate of cost increase through various measures for 2015 and 2016. And on this slide, the first 2 measures, Express Scripts and CVS Health, those are the 2 largest PBMs, or pharmacy benefit managers, in the country, and they've begun reporting what their actual rate of increase is rather than what the rate of increase is off of the list price, which is more than they pay. They used to report that way. Now they're starting to report report their actual rate of growth. And you can see here that in 2016, we were at 3.8 and 3.2%. I didn't have room on the slide to add the growth rate reported by Optum Health, which of course is headquartered here in Minnesota, but Optum Health reported for the 12 months ended November 2016 a 2.8% rate of growth. And they're all reporting that many of their clients actually experienced a reduction in 2016 relative to 2015. And again, these are the retail drugs that make up the bulk of drug spending. I'll cover the other drugs in a moment. CMS, which keeps the national health expenditures, is reporting about 5%. And I think a big reason, one of the significant differences here is that Express Scripts and CVS are reporting on a per person basis. CMS doesn't adjust for the growth of the population year over year, so you get about a percentage point there. And then finally, Quintile's IMS Health. This is a really interesting measure because it's covering all medicines. This is both the retail medicines and the medicines that are physician administered. And again, like the CMS numbers, it's an aggregate. It's not adjusted on a per person basis. And they're showing that the growth rate in 2016 for all medicines was about 4.8%. So we've had significant changes in the marketplace. I have, heard, the term monopolies used frequently, but I think that as we look at how the marketplace operates, we see a somewhat different story. So this graphic, which was produced from data collected by IMS Health, shows the difference between the manufacturer list price, that's the publicly stated price, and the actual price after taking into account the rebates that lower the cost for purchasers of medicines, whether they be insurers, it could be states, and so forth. And as you can see, in recent years, we've had a really growing gap between the list price and the actual price, and this averages out all medicines, retail and non-retail. And in recent years, we've been in the, we'll call it the low to mid single digits. A lot of times insurance claims, when analysis is done on the basis of those, they're actually looking at the list price, so you can see that there can be a very, very big difference and that there's a significant amount of discount that lowers the cost to the purchaser that typically isn't reflected. Next slide. This slide breaks down national health spending. This works at the national level into the various categories of spending. And this begins with the government's data, which tracks the retail drugs, and through additional work based on IMS data and through the Altarum Institute, a nonprofit healthcare research organization, it worked to correct or to accurately portray the spending for all medicines in the national health accounts rather than just the retail medicines. And here we find that the spending, the share of the healthcare dollar overall going to medicines in 2015 was 14%. That 14% is further broken down. Most of the time when people discuss the cost of medicines, my experience is that they essentially assume that all of that spending is going to brand manufacturers. But in fact, when we break down where the spending is going, we find that about half of the total spending goes to brand manufacturers, and the rest is split between generic manufacturers and the distribution chain for both brand and generic drugs. So the brand, all of the brand drugs out there today account for about 7% of total health spending. Next slide, please. The growth rate projections are for medicines to grow roughly in line with national health spending for the next 10 years, just as they typically have over long periods for many years in the past. There's obviously a spike that occurred in 2014, and that's a result of both 16, 17 million additional Americans gaining coverage in 2014, as well as the introduction of new hepatitis C medicines that were essentially a cure for well over 90% of the population. Hepatitis C was a condition that was generating a growing, significant growth in healthcare costs on hospitals and physician services, and the projections were that the cost would continue to grow. And with the introduction of a cure, We had, for the first time, a cure for a disease that actually was fatal on an annual basis to 5 times as many patients as HIV at the time. The point I'll make about this is that when the medicines were, when the first new medicine reached the market, the price was widely reported as $84,000 for a course of therapy. Within a year or so, 13 months, we had the second medicine in the class, and based on publicly reported data, the price came down between 40 and 65%, and publicly reported information suggests that the price trend continues to decrease as additional competitors enter the market. So I think that that's quite a different situation than a monopoly situation. And the reason the price came down is that the competing drugs gave the purchasers leverage that they exercised because they don't have to cover all drugs to extract the discounts. I'll add that there's often a question of how can we have projections for roughly level drug spending when we have so many new drugs coming? And there are 2 answers that I'll provide briefly. One is that we have a lot of downward pressure that's exercised by the market, which I've already discussed a bit. And second, we have a unique type of cost containment that applies to medicines that actually doesn't apply in any other sector of healthcare. So in the United States, 90% of all of the medicines that patients use are generics. And now, in addition to generics, we actually have the first biosimilars entering the market, and there's a robust pipeline of biosimilars poised to enter the market. So IMS projects that over the next 5 years, $140 billion worth of brand drugs are going to be facing generic and biosimilar competition. So we have a system that moves resources over time by establishing generics, biosimilars at lower price points. Patients continue to use those, and then it frees up resources that can be allocated to innovative medicines. So we're able to have both greater affordability and continued medical advances. Next. This slide shows the share of spending by the extent to which increases in healthcare spending over the next 10 years are projected to be attributed to medicines versus other parts of healthcare. I think the common perception is medicines basically are driving all of the growth in healthcare spending. This data, which is similar to the data I mentioned earlier from similar sources that captures all medicines, retail and non-retail, estimates that the total increase in healthcare spending will happen over the next 10 years will be 5 times as large outside of medicines in absolute dollars than the growth in spending on medicines. Next slide, please. Again, I've already touched on the issue of the pharmacy benefit managers, so I'll be very brief here. The market, much of the market is structured around pharmacy benefit managers with a great deal of leverage to negotiate prices with pharmaceutical companies, and that's why you're seeing the very sizable growth in the discounts that I mentioned earlier, because you do have very powerful, sophisticated purchasers who have a lot of tools at their disposal with which to negotiate. In fact, because they typically aren't required to cover all medicines, they're able to use these tools like formularies and tier placement and so forth. I'm going to skip over to the next slide, which is a repeat of a previous one. And then I'll briefly note that the terms of competition in the biopharma sector have really changed quite a bit. If you go back to the 1970s, when a company brought out a new type of medicine, a first-in-class medicine, it often took 10 years before the second medicine arrived. More recently, as you see here in the late 2000s, the average had dropped to 2.3 years. And for some of the most prominent medicines that have been introduced since then, as I mentioned, hepatitis C, it was about 13 months before the second medicine arrived. And for new kinds of cholesterol medicines, it was actually about a month. Next slide, please. Here, I'll just note that different countries have different systems, but they all spend roughly similar, all the developed countries spend roughly similar shares of their healthcare dollar on medicines. The level is different. The level of spending on healthcare overall and on medicines is different. But the differences between U.S. and foreign healthcare spendings is not really driven by medicines as is commonly perceived. I will note that while the shares are similar in the U.S., we tend to have better access to medicines. We see, for instance, in the EU, delayed and much more restricted access to cancer medicines. Next slide. Here I'll note that much of the discounts that are negotiated by payers don't necessarily make their way to patients at the pharmacy. So we often see situations, because those discounts aren't passed through at the pharmacy, that the patient is paying cost sharing based on the list price of a medicine rather than on the final price of the medicine, which can be discounted quite heavily. So we do think it would be useful to work toward a pass-through of those rebates in a way that would maintain the confidentiality of the particular commercial transactions while getting the patients the benefit at the pharmacy counter of the discounts that are being achieved. And finally, I'll note in just a couple of slides the very large-scale R&D effort that the sector drives. You see here that according to National Science Foundation data, 17% of all U.S. domestic research and development funded by business is through the pharmaceutical sector. And there are many similar measures from the National Science Foundation, from the Brookings Institution, that show the R&D intensity. The Brookings Institution shows that the pharmaceutical industry is far and away the industry that invests the most per worker in R&D at about $130,000 per year in R&D. No one's even close to, no other sector is even close to that. Next. It's also the case that as this R&D effort is made, an awful lot of it does not lead to approved medicines. You see here some numbers that look rather daunting, unsuccessful attempts versus successful attempts. And ultimately, this means that A, you need a lot of persistence to make a medical advance, and B, the very small share of medicines that enter trials that are approved, and then the even much smaller share of medicines that are approved that become commercially successful are the medicines that actually finance the entire biopharma sector. When we do get medicines out of the pipeline, they can be medical advances. They also can have positive effects on other healthcare spending. So the Congressional Budget Office, for instance, has found that in Medicare Part D, additional use of medicines leads to savings on other Medicare services like hospital care, and they now incorporate that into their budget estimates. And there's a wealth of research, some of which is displayed here, which indicates the opportunities to achieve both better health and more efficient, more affordable use of healthcare resources through medicines that help keep people out of the hospital. And I'll just close by noting that there's an array of areas that we think are opportunities for further progress in making the market work well, such as promoting more value-driven care around pharmaceuticals. Mr. Chairman, members, thank you very much.
Thank you very much, Mr. Smith. I appreciate it. At this point in time, if I could ask Dr. Stephen Schondelmeyer to join Mr. Smith at the table, we'll begin our question and answer session. Thank you very much. Appreciate it. I'll take this moment just to say thank you again. Thank you, Mr. Smith. I think that we did ask you on relatively short notice, and thank you for putting together a very cogent and helpful presentation. As a practicing family physician, I would say that I've often thought over the 35 years that I've practiced medicine that some of the greatest tools I've had at my disposal to treat patients have come through the pharmaceutical industry. And it would be unlikely for any family to go from birth to the grave without having seeing someone benefit dramatically from these advances. So thank you. I think in this day and age, it may seem like your industry is being picked on. You might have picked that up. So having said that, questions? Senator Pratt.
Okay, well, thank you for coming today, and a very good presentation. You know, I think what's interesting is the amount of money that you do put in R&D and the reason why you are granted a patent and exclusivity for a period of time. When Mr. Schondelmeyer was here last time, I asked him a very pointed question that he couldn't answer, and that was, and he had some examples. He showed me a chart on verapamil. I don't know why you guys can't name these things something that are pronounceable, but there was a period of shortage where the drug went from $2.08 per injectable up to $8.73. And after the period of shortage, understanding the price went up, it continued to rise. There's another drug here, well, the EpiPen. Okay, in the 3 years from in the 4 years from 2005 2009, the cost went up 18%. In the 3 years from 2013 to 2016, the price went up 250%. Humulin, we saw similar types of increases. And so, you know, while I appreciate that you talk about the cost of drugs as part of the overall system, you can't deny that there's been exorbitant inflation in some of these drugs that aren't new, that have already paid back their R&D costs. And when I asked Mr. Schondelmeyer this, he said, well, I asked the drug companies.
Yeah.
So I'm asking you, why?
All right. So,
Thank you, Senator Pratt. Please go ahead, Mr. Smith.
Mr. Chair, Senator Pratt, thank you. So let me work at this in pieces. So I don't know all of these specific drugs, but let me try to give you an answer in categories, okay? So I did recognize one, insulin. And you know, I can't comment on, I don't know the details of the pricing of specific drugs. In fact, as someone who works with an association of competitors, we're prohibited from getting, you know, pricing information of that type. So I can only work with what's in the public domain. But I think insulins generally are a good example of how the market is changing. So I've seen, you know, many of the reports about insulins, you know, having, you know, very significant price increases. At the same time, it's become evident through a lot of data that's made it into the public realm that the discounts that are negotiated on insulins are very large, and they're often pegged at the 50 to 70% level. And I know that there are analyst reports that have indicated that basically the discounts that are growing by leaps and bounds are basically keeping, you know, prices, the actual prices after the discounts level. With insulins, it actually is an intensely competitive market that generates that kind of result. Now, it may be that that a patient, and this is a, you know, significant issue. A patient using an insulin may be charged by their health plan while the patient is in the deductible. They may be charged the deductible based on the list price. And again, as I mentioned, we think one productive area is to start working on ways so that the patients benefit at the pharmacy counter while maintaining the incentives for those deep discounts at the same time. There are other categories of medicines, and I don't know all of the medicines that you mentioned that you know, in some areas there have been bad actors who have gotten a niche and have been able to, you know, significantly increase price or chosen to do so for one reason or another. We think that there are solutions to that. In many instances, these are off patent. medicines or generics. We think that there need to be incentives for more generics to enter the market, and we think that that's a good way to address these issues. For something like the injector, we think that there are opportunities for FDA rules around products that combine a medicine with a medical device. We think there are ways to make those rules more inviting of additional competitors.
Thank you, Mr. Smith. Senator Pratt, do you have a follow-up for Mr. Smith, or can I let Dr. Schondelmeyer go ahead and answer and respond?
Please, go ahead.
Dr. Schondelmeyer, would you please share your perspective on that same question from Senator Pratt? Thank you.
Sure. So again, why have these gone up and the opportunity? I would acknowledge that there are different behaviors among different drug companies and different products, although in the examples I showed you, some were small companies that are not traditional R&D-oriented companies that might be characterized as bad actors. Some might be generic companies, but some are brand name companies, and some are old-line traditional R&D companies. So I don't think we can paint the brush that this is only rogue companies and only bad actors and only generics. It also includes brand names. My point and take out of this is the structures we have in the marketplace aren't disciplining bad behavior in the market. And so we need to find other ways to identify, let's name what bad behaviors are and develop incentives to do that. And I would advocate doing that, but not in a way that hurts true significant innovation. The target here isn't to prohibit the Hep C drug or the CAR T that came to the market recently from coming to the market. That's not the target. I haven't said that, and no one, very few people say that's their target. But we do need to discipline the bad behaviors that in aggregate waste a lot of resources and take capital out of healthcare and capital out of our marketplace that could be reinvested in true innovation rather than capital removal from the marketplace.
Thank you, Dr. Schondelmeyer. I have a follow-up question for that. Mr. Smith, regarding the earlier comment about some sort of rate or price accountability commission that might be available to exactly do what Dr. Schondelmeyer said, look at some of these behaviors that are aberrant, identify some metrics that would classify behaviors as aberrant. The verapamil discussion where a temporary shortage caused a price increase, but when the shortage went away, the price increase didn't flip back, it just kept going up, or the same thing with the EpiPen. What would your thoughts be in regards to that? You're probably aware of the fact that there are some states that are looking into creating just that, and we do indeed have that precedent already established as states, and I think Minnesota is one of them, where we do review health insurance premiums, and we have this entire timetable and things like that. What would your thoughts be in that regard, sir?
Yeah, thank you, Mr. Chair. Generally, I think that I would argue that we ought to be removing barriers to competition in the market rather than going in the direction of creating that type of commission. I think that some of the measures that I mentioned earlier, incenting additional generics into the market, for instance, will address a wide range of that. I really think that there is, ultimately a direction around this type of commission that I think is not likely to truly recognize innovation versus these other behaviors that ought to be disciplined. So I think that we ought to be looking to beef up our market to discipline these behaviors.
Thank you, sir. Any other questions? Senator Fratz.
Mr. Chair, thank you, Dr. Schondelmeyer, Mr. Smith. We've had the discussion of pharmaceuticals on this committee already, and so some of these questions have come up. But if I'm reading your charts correctly, Mr. Smith, the invoice price has gone up 54% since 2011. setting aside the issues of rebates, which I'll get to in a minute. Does that sound right to you?
I haven't thought about the invoice price because I've been so focused on the actual price. I haven't actually. I don't have that number in my head, but I will take your math for that.
I've taken it from your exhibit picture.
Yeah. No. That. Yeah. Yeah.
And as far as we're talking rebates, discounts, that's something that the seller provides to incentivize the buyer to buy its product instead of another product.
Yeah, it is a way to get the buyer to buy the product because the buyer controls access to the marketplace and controls access to patients.
And you heard Dr. Schondelmeyer's presentation earlier, where his concern, which is shared by members of this committee, is that it incentivizes the patient to buy a pharmaceutical that, while it may be a lower cost after the rebates considered for the patient, is a greater cost to the system and sometimes much greater. Do you have any response to that?
So, yeah, I think that there's a couple of things that I would mention. One is that, we agree that, it would be desirable to create more room for value-based arrangements rather than arrangements that are, targeted directly at discounts. There are some handcuffs on us in terms of doing that, largely under federal guidance. And I think that, one of the productive areas is to open up room because I think both manufacturers and purchasers, want to do that. I think that it is the case that in aggregate, we're absolutely seeing a lot of downward pressure on cost, and that's why we're seeing, the kinds of numbers that I showed you from the PBMs and from other sources. I'm not going to, I don't agree with every practice that the PBMs use. I think it would be better for, some things to be different. But I think, we also shouldn't ignore that there really is significant cost containment in the system today, and that often gets lost in the discussion.
If I could,
Senator Frentz, please feel free to follow up.
And then finally, again, thank you for your presentation, both of you. I think most people in this room would like a short, direct answer, if you can, to if a person in Canada pays $9 for a pill, can you tell us why we pay $170 for that same pill in the United States?
Okay, I would beg your indulgence to go a little beyond short, but I'll try to tick off a few factors. Medicines do have different costs in different countries. There's a couple of things that I would point out that may account for that difference between Canada and the U.S. One is most of the data I see has a couple of flaws that tend to exaggerate the difference. One difference is that they look at the final price in Canada, but they don't look at the discounted price in the U.S. Another difference is that I see a lot of brand medicines on those charts where there's virtually no utilization of them anymore, where 99% of the utilization is of generics that are cheaper than what's being paid in Canada. So in the U.S., our whole system has been built to use generics to the max. We use more generics. They're cheaper here than they are there. In fact, we find that a lot of the drugs that come into the country, from outside, are brand drugs for which there's a generic in the U.S. that would have been lower cost. And then third, I'll say that many foreign countries, including Canada, have government price controls. We think that this is not something that would lead to a good direction in the U.S. We think that it will inevitably severely suppress innovation. Frankly, Canada doesn't have to worry about innovation that much because, they get some benefits from the innovation that's generated here. But, if the U.S. moved to that kind of market, it would be an entirely different situation that I think would, severely diminish the industry's innovative capacity.
Thank you, Mr. Smith. Dr. Schondelmeyer, did you have any comments you wanted to make on that last question from Senator Frentz?
Briefly, the question was about why would a drug cost $9 in Canada versus 100-something in the U.S.? And there are many answers. Certainly there's a different scheme in Canada. They do have a rate review process in Canada. They only regulate probably 5 or 8 drugs a year. They review most all that come on the market, new patented drugs, but the only regulator set the price of a very small number that are considered to be egregious or out of bounds in terms of reference-based comparisons and comparisons with other countries. I guess what I find puzzling about the arguments that we hear from the brand name companies in this case is that Canada's a free rider and they're just taking advantage of our R&D, and we're so big that, you know, it would hurt the world if we cut back our pricing and R&D. In most markets, the largest buyer usually gets a better price. We buy more drug. We pay for 45, 50% of the world's pharmaceuticals, and we pay the highest price of anywhere in the world. Something about that tells me it's not a normal market. Again, I'm all for finding ways that provide targeted and effective rewards for innovation. But I think our marketplace is so loose that big companies and small companies, brand names and generic companies, can abuse that system. And it's not just the drug companies, it's all the players down the line where the rebates trickle down and don't get to the consumer. All of them are part of that process. We've created a system that's so complex, our national health accounts don't add up the amount that we spend on administering and chasing and tracking rebates. And if you think about what is a rebate really, a rebate that, as Mr. Smith points out, maybe a third of our total revenue to drug companies ends up going back in rebates and discounts. Rebates are an overpayment for the product up front, and it's essentially a loan for 6 to 12 months to the drug company that then we have to chase and get back from them. Why are we in the business of giving rebated loans to drug companies and then chasing it back later? We need to change the system.
Thank you, Dr. Schondelmeyer. I appreciate that. Mr. Smith, I think you're entitled to respond to that if you
Sure. I'll be very brief. You know, we really are talking about two systems, one in which a market with very large, sophisticated, powerful purchasers, but multiple private sector purchasers are purchasing, and then a market where, you know, basically the government holds a monopoly. I think that the market with the private, I don't think we should necessarily assume that they get it right in the system where the, you know, government holds the monopoly over purchasing, and that we get it wrong in a system with multiple private purchasers who are very sophisticated at purchasing. I'd also point out, or I'd just briefly reiterate my point, that in all of the countries where we've seen, you know, the government price controls, we also see that they're combined with access restrictions that I think would be unwise.
Thank you, Mr. Smith. Senator Pratt.
Thank you, Mr. Chair. I want to thank my friend, Senator Frentz, for bringing this up, but as a lawyer, I wouldn't expect him to understand compounding, so I let the banker and me do that.
Thank you, Senator Pratt.
To actually see that over that period of time in your chart, your list prices actually went up 86%. Mm-hmm. And your net prices actually increased 38%. For a 14% annum increase on the list price, 6.3% per annum on your net price. Mm-hmm. And I think that, you know, for either of you, somebody is paying the cost of these discounts. I find it amazing that gap was so tight and then exploded,
yeah.
Right? And it reminds me, kind of as a corollary, and I don't mean to confuse the situation, I talk to private colleges whose list prices of tuition have been going up, and they say, oh, don't worry about it, Senator, the state grant program keeps the net cost to students pretty level. Well, it does because we're paying the subsidy.
Right.
We're paying for those increases. Who's paying for the rebates and discounts? Is it the ratepayer who's paying based on their drugs based on the list price?
Right.
Is this happening because we've messed up the reimbursement system, as we heard from Lakewood, mm-hmm. to where they'll reimburse on the list price, but knowing help me understand that, because somebody is paying for that gap.
Mm-hmm. Thank you, Senator Pratt. Mr. Rice. Mr. Smith, excuse me.
Thank you, Mr. Chairman. Senator Pratt. So I'd say that I think of the discounts as essentially lowering the final cost to the purchaser. I mean, at the end of the day, that's what happens. The manufacturer is ultimately accepting less payment for the medicine than is indicated by the list price. So I think that there are savings to the system. Now, how those dollars are used as they're sent back through the PBMs and the health plans, is a different issue. As I've indicated, certainly in the past we didn't have very often deductibles that applied to medicines. Medicines were recognized being outside the deductible. Since 2012, 2013, we've had a lot more plans with deductibles. And when that happens under today's system, it is the patient at the pharmacy counter being charged list price, which leaves them, I think, in a situation where they're paying more out of pocket than they ought to be.
Thank you, Mr. Smith. Dr. Schondelmeyer, any comments on that? Don't feel obligated. Okay. Senator Pratt, any follow-up?
Maybe.
If you want to take a breath, go ahead. I'll just come in with one quick. In regards to coupon programs, co-pays, things like that, as a family doc and been out 35 years, I've gone through the whole, if you will, evolution of where we used to have drug rep lunches, sometimes donuts in the morning, and we would be exposed to the medication. We'd talk with the pharmaceutical reps, and they would share with us the information and what kind of patient population would best benefit from certain medication, things like that. And there was a time where there were some creative incentive marketplaces, tools put in place where if a physician prescribed 10 prescriptions for Inderall, they would receive a VCR after the 10th one so they could watch more continuing medical education. But there was no way to prohibit you from taping the latest Disney movie as well. So we've gone a long ways. And today, the three tools that I see, and I worry most because I teach at the medical school, that can sometimes unduly potentially influence young residents are coupons, samples, and drug rep lunches. Now, I've advocated for drug rep lunches because we sit down and for 5 to 15 minutes, we get a chance to ask questions about this new product, if it's a new insulin, if it's a new hepatitis C product, whatever it is. But to me, there's diminishing value now with the coupons. I think the samples really steer us in the wrong direction. And I read a disturbing report that on a new drug launch, for every 1 to 2 minute increment of time a pharmaceutical rep can spend with a physician, the use of that product will go up 16% by that physician in terms of writing the prescription. As we go forward as a committee, trying to make recommendations to the legislature, we really want to be fair, but we think that something needs to happen in this realm. Mm-hmm. Dr. Schondelmeyer actually shared a statistic that if you actually include retail prescriptions, physician-administered drugs, and also hospital-administered drugs, we're actually not at 14, we're not at 10. We're actually closing in somewhere around 22, 24, 25%, somewhere. But regardless, the bottom line is we're really up there. I mean, inpatient numbers have come down from 32, 33% down to, in some situations, if you take the inpatient-administered drugs out of play, you're down into the mid-20s. And now, if you put all the pharmaceuticals in, you're up to the mid-20s. So it's a new world. What would you say about the coupons and the samples and the pharmaceutical lunches in terms of your position? Okay. Thank you, Mr. Smith.
Sure. Mr. Chairman, thank you. Let me, I'll say two things. One, just very briefly, I do want to be clear that, our numbers, which I stand by of 14%, include everything. Okay, they include the drugs administered in hospitals, in clinics, long-term care, physician offices, and so forth. And we'll be glad to, work with you in sort of getting to the root of this difference, because I'm quite confident that our numbers will stand up well and that 14's right. Second, on these issues, I think that I would just, I would say that, I hear the concern about the influence that pharmaceutical companies can have on prescribing. And as I look at what's happening in the marketplace, as I look at the patterns of utilization of medicines, what I see is that year after year after year, our generic share is going up, and we're currently at 90%. So whatever the pharmaceutical influence is on prescribing, it hasn't kept generics from getting to, to 90%. On coupons, I see that many coupons are used for specialty medicines where the plan has prior authorized the medicine saying, that's the right medicine for the patient, but they're still going to charge them very high cost sharing. I think that, the coupons can help in terms of the affordability and maintaining adherence and so forth. So I guess I would just sum it up by saying that there's a lot of influences on prescribing. It's a lot more than pharmaceutical companies by a long shot. And as you think about this, I think I would just ask that you take a comprehensive view as to how the market is working and what the full range of influences are, and also recognizing that the biopharma industry actually, we do have an interest in seeing medicines used. It's really hard to get medicines to get uptake in the first place. And I'm sure, Mr. Chair, you're aware of all of the data showing the lengthy time it takes to go from bench to bedside. So I think it's important to sort of understand the full pattern of utilization, the full range of influences, and not assume that there is some type of industry influence that just overrides the rest, because I think the patterns clearly demonstrate that it doesn't.
Thank you, Mr. Smith. In regards to potentially my assuming about your numbers, the slide that you used, you'd referenced that retail and physician-administered medicines constituted 14%. And because you hadn't said hospital-administered, I thought there was a chunk missing. Yep. But you're indicating that the hospital-administered portion is in that as well. Okay,
yes.
Thank you.
Yes,
I appreciate that.
And I apologize. We should have labeled it differently. We're using shorthand.
No, you put together a wonderful presentation. I appreciate it. Thank you, Mr. Smith. Senator Klein.
So a comment and a question, I guess. The suggestion, I guess, that for some of these more outrageous pricing deviations, one response might be to dysregulate a bit and encourage free market competition among generics. And that seems to me to be a blunt and a slow and an ineffective tool. If you take sort of the classic example of Daraprim, a very cheap antiparasitic, which was effective for people who had HIV, a small set of patients. And then, of course, the gentleman, the pharma bro, who became the only producer of that small medication and jacked up the price significantly. If our only societal response to that behavior is to sort of dysregulate that market and try to encourage other people to make Daraprim, which really has a small market in the first place, I don't think that would be effective, and I don't think it would be prompt. That was my comment. My question, I guess, is about direct-to-consumer advertising. And I just want you to touch on, obviously, as a physician, it causes us a lot of headaches and heartaches, and I'm sure you're aware of those, and I wonder what your position is on that.
Thank you, Senator Klein. Mr. Smith.
Mr. Chair, Senator, thank you. So on direct-to-consumer advertising, I recognize that it raises questions like the question you raised. So in terms of my position, I would say a couple of things, and some of it is going to harken back to my prior comments, so I'll be brief with it. Number one, I do think it's important to recognize that pharmaceutical companies are far from the only healthcare entities that advertise. There's a lot of advertising that goes on for healthcare overall. We are, however, uniquely regulated. Our advertising is uniquely regulated to a far higher standard due to the FDA requirements, and that's why on our ads, unlike other ads, you get you get the lengthy recitation of side effects and all of the things that you're aware. So we're not alone in advertising. We are alone in the most rigorous regulatory structure for advertising. My second comment would be that similar to the issues raised by the chairman, I think that advertising is often viewed as some type of overwhelming influence that, simply drives prescribing on a one-to-one basis. And Senator, I don't mean to say that that's exactly what you suggested, but that's sort of, in many discussions, it seems to be sort of what the underlying, concern is. And, again, as I look at the influences on prescribing, I don't see that because I see that access is heavily controlled by the payers and the decisions they make about which drugs to cover and not to cover, because they have a lot of opportunities to make those differentiations. And I also see, the research that indicates that DTC, whether people, find it appealing or not, that DTC gets patients in to see their physicians at an earlier stage of disease, and that it also can even help a little bit improve adherence, which is in many instances poor, and which is one of the great, opportunities for, better health outcomes and savings if we could actually make progress against adherence. So for those reasons, I believe that DTC plays a useful and constructive, role in the system, while recognizing that it's a question that I'm commonly asked.
Thank you, Mr. Smith. Any other questions? Senator Pratt.
Thank you, Mr. Chair. And actually, I have two questions, and I think the first one is for Mr. Schondelmeyer. I have a concern with your proposal to establish a price oversight review commission. I guess my question would be, when you do that, who determines what is fair? And what is the cost of compliance? Won't the cost of compliance just increase the cost of making these drugs available anyway?
Well, thank you, Mr. Chair, and thank you, Senator, for that question. First of all, I would point us to who determines now what is a fair price. And I don't think we have anybody making that decision in the healthcare system, which is why the curve isn't bent down very much. Nobody's really making, the physician does a safety effectiveness evaluation, what's the best therapy for my patient. Physician, even if they wanted to make a value choice, doesn't know the real price because the contracts from the drug company prohibit disclosing the rebates that the PBM or somebody else gets and knowing where it is. The PBMs don't disclose the rebates because, again, their contracts with the drug company prohibit disclosing that. I would argue there's nobody making a true price value decision now. One could, in the other countries that have these regulatory commissions, they have physicians, they have pharmacists, they have health economists, they have ethicists on these boards. They construct the best of individuals with experience and knowledge of these markets to make those evaluations, and they are very explicit about the tools they use and how those judgments are made. So yes, it's difficult to determine what's a fair or reasonable price, but I think having an organized process and an explicit process and an intentional process is better than what we have right now.
Thank you, Dr. Schondelmeyer. Mr. Smith, would you like to respond to that question from Senator Pratt?
Yes, Mr. Chairman, thank you, and thank you, Senator Pratt. So I have a concern that this type of essentially centralized government price setting is completely unsuited to an industry that actually needs to make enormous investments in things that fail in order to get to things that work and things that are good. I think that there is little likelihood that you would have a group of philosopher kings who would get it just right. I think that, or who would ultimately recognize, the risk entailed and so forth. I think that it's also, understating, as Dr. Schondelmeyer put it, what we have now, to not recognize that we actually have quite large, sophisticated, capable purchasers with lots of tools at their disposal, and B, a whole lot of other things going on in the system that are changing incentives. So, for instance, we have more medicines increasingly are sold to organizations that are at financial risk for the cost of care in its entirety. And that presumably makes them sensitive to looking at, is this the medicine we want to use, or is this one? This one is more expensive. It's worth it because it's going to keep patients out of the hospital, or no, it's not worth it, and we're going to use the cheaper one. So I think that's where our system is heading. We would like to be a bigger part of that system through a transition to more value-based contracting in the marketplace. But I don't think that you would see anything that nuanced or effective if we simply impaneled a group to make these decisions for all of us.
Thank you, Mr. Smith. Senator Pratt, follow-up?
Not a follow-up, a little bit different question, but along that line, I understand the desire. I don't necessarily agree with it. Senator Frentz and I had, a couple of months ago, had long discussions over several bottles of wine over the free market system, but it seems like in this case the supply and demand equilibrium is broken down a little bit. You can't deny that when you look at some of the charts, and so I'd like to try to figure out how to fix the market so it works more efficiently. But my second question, and I'd like both of your thoughts on this, you touched on but didn't really delve into the idea that pharmaceuticals can help lower the cost of health care by keeping patients out of more expensive treatments. Could you touch on that and how this committee might utilize that information in its deliberations?
Thank you, Senator Pratt. Mr. Smith, why don't you go ahead and lead?
Okay. Mr. Chairman, thank you, and Senator Pratt, thank you for the question. So there is, there's a large body of literature showing that you can get savings by better use of medicines, and the medicines overall can help achieve savings by keeping patients healthier out of the hospital and so forth. And as I mentioned, that actually has been officially recognized by the Congressional Budget Office when it does estimates around policies affecting Medicare Part D, which is, as you know, a large program that's a large portion of the market. I think that, as we see more movement to value-based contracting, those considerations will become more important. They'll become more prominent in the calculations that are made by the purchasers. As I mentioned, they may say, we're willing to pay extra for this newer drug because it does more on that side of the ledger, and that's what it's all about. I think it'll become more prominent as we have healthcare delivered through organizations that are at financial risk for the spectrum, the full spectrum of costs of care, rather than just pieces. As to how this committee could take better advantage of this phenomenon, that's a great question. I don't have a great answer for you right now, so I'd like to offer, if we can think about it and submit something following the hearing, we'll be glad to do so.
Thank you, Mr. Smith. I appreciate that, and I appreciate your candor. Dr. Schondelmeyer.
Yes, I appreciate Mr. Smith's thoughtful response, and there were several buzzwords that were thrown out there that I want to back us up a bit and remind us to think about and put them in a broader framework. One was value-based pricing, contracting, payment. And while I think there's some hope for value-based approaches to things, it's very critical, just like with any piece of legislation, that we define our terms carefully. And what do we mean by value? On the one hand, if I'm a board member on a corporation, value is the return to my stockholders, more revenue. It doesn't matter what happened in the marketplace necessarily, but more return to my stockholders. On the other hand, if I'm a patient paying for health care, value is how much did my health care improve for the amount of resources I had to give up to get that health care. So value here, sometimes they work in the same direction, but sometimes they may work in opposite direction. Sometimes value-based contracts mean maximizing revenue to the producer. Sometimes value-based contracts may mean managing the resources spent by the consumer or the payer. So we need to be careful with our terms, define them very carefully, and I've seen value-based used in all of those contexts. Second, I think risk-based, there are very few true risk-based contracts out there today, even though they've been dabbled with, and most of them have risk corridors that you're at risk for 1% to 5%, and then after that, we'll pay for the costs anyway. So you lose a risk band, but you don't really have full risk. And so the market isn't fully operationalizing these concepts. I did want to get back to one comment earlier, and I apologize for backtracking, but the question was asked about direct-to-consumer advertising. And there have been a number of studies that have evaluated direct-to-consumer advertising. Most of those had a one-sided hypothesis. What is beneficial about direct-to-consumer advertising? And there are some beneficial aspects of direct-to-consumer advertising. But even as I think Mr. Smith in his comments acknowledged, that ad drives patients in to see the doctor. Some needed the medication, got evaluated, and were treated with it. That's a good thing. Some didn't need the medication. They went in and talked to the doctor, consumed time of a doctor's visit, added an extra visit to the health plan, to the cost of whoever's paying the bills for doctor's visits. They add cost and time and effort to our system that really aren't productive, and that I would describe as being akin to pollution. If I'm a manufacturer producing a product and dumping out black smoke in the air, somebody in the state's going to come to me and force an abatement on me and make me either clean it up or pay penalties to clean it up. And the direct-to-consumer advertising does increase the number of physician visits, some of which aren't necessary, and somebody other than the drug company is bearing the cost of those. So I think we need to look carefully at direct-to-consumer advertising and the negative, both economic and clinical consequences, as well as the positive consequences.
Thank you, Dr. Schondelmeyer, and no apologies from you necessary for backtracking on that one, because it was my error in not allowing you to respond originally. Senator Klein, do you have a follow-up question for him? Okay. Senator Frenzel.
Thanks very much, Mr. Chair. Thanks. This has been a great presentation. I just want to show Senator Pratt that my math skills are still primitively intact by pointing out, Mr. Smith, when you talked about the avoiding expensive hospital services, those savings are listed here for congenital heart failure, diabetes, and I'm sure a number of examples. I hope you'd agree with me that those savings will be accrued to those patients regardless of what the patient was charged for the medication. The question of what the insulin costs does not affect the savings. They're going to have those savings, and we're really here talking about the cost of the medication itself.
So Senator, I guess I would have a slightly different formulation. I think that the array of medicines that are available to the patient is dependent upon having a market-based system. I don't think patients would have the same array of medicines available, either developed or access to them, if we didn't have a predominantly market-based system.
Thank you, Mr. Smith. Senator Pratt.
Thank you, Mr. Chair. Mr. Schondelmeyer, you talked on the idea of value to the patient, which made me think back to Minnesota Health Action Group's Choosing Wisely. And so when profit is not an evil that exists in our society. In fact, it's good. It drives innovation. It drives the growth in life-saving drugs that we've seen today. How much of that value to the patient, though, is really due to lack of transparency and being able to judge wisely versus the competing factors of what is value?
Thank you, Senator Pratt. You'd like Dr. Schondelmeyer to answer first? Please feel free.
Thank you, Mr. Chairman and Senator. I'm not sure I really understand your question. What?
Well, you said that the drug company, their version of value is returned to investors, but
right.
You know, boy, is that this? But the value that a patient sees versus the cost, and yet the patient is not without choices here. And so you tried to make a distinction between what is value and trying to say, in my impression, say that the drug company's value is less pure than the patient's value, but the patient has choices. The patient has the ability sometimes to make a better choice as well. And so I was just, when you talk about patient value, where does choice, as we saw in Choosing Wisely, fit into that?
Senator, Brad, thank you, Dr. Schondelmeyer.
Thank you, Mr. Chair and Senator. You've helped define the question. I can answer it a little better. I think patients do have a responsibility to be wise decision makers in the healthcare system. But patients find it difficult to do that because they can go to the pharmacy, and the pharmacy, first of all, they're gagged from telling the patient that that prescription is lower cost if you pay cash sometimes versus what the copay is. And even if they aren't gagged from doing that, they can ask the pharmacist, what does it cost? And the pharmacist can tell them what they're paid by the PBM. They don't know how much the PBM gets in a rebate, and they can't find that out. I at an age where I had to have a colonoscopy not long ago. And when I went into the diagnostic center to have that colonoscopy, I asked the receptionist, before I do this, I'd like to know how much will this procedure cost? She says, oh, I don't have that information. I can't tell you. Ask the nurse. I asked the nurse. Oh, I don't have that information. Ask the doctor. Ask the doctor. Oh, I don't have that information. You have to talk to people in accounting. Oh, okay, I'd like to do that. Oh, they're not here. They're in another building across town. Our system's built so you can't get to the information to make value-based decisions in healthcare. The patient who wants to be conscious can't do that. And I don't think all of those people consciously hid it from them, but we built a system that insulates and isolates patients and decision makers from the information to make value-based decisions. That's the point I was really making. And I'm not opposed to profit or shareholders making money, but I think we have to have a market. I like market-based systems, but we need a market-based system that disciplines itself. And I think we have plenty of evidence that in the pharmaceutical marketplace, there are a lot of bad actors and bad behavior that aren't being very well disciplined in the marketplace, and it seems to be growing rather than shrinking. That's what concerns me, and I think we have limited resources as a society. Our Congress right now is debating some new tax laws, hopefully to reduce our taxes, but that means we'll have less to spend on Medicare and Medicaid, yet all of the pressures. What I find amazing and amusing is that we hear all kinds of this will save money, that will save money, this will save money. Are we spending less on health care than we did today than we did last year or the year before or others? We have to look at how we set our frame of what saves money. I noticed, I applaud the new drug, the CAR-T. It's I think, probably of the same magnitude as the Hep C drugs in terms of bringing real innovative therapeutic value to the marketplace. But I found, again, interesting that the drug company in presenting their price said, you know, we've saved the market a lot of money. We came in the market at $475,000 per treatment, and we had contemplated coming in at $800,000. So since we contemplated $800,000 as a treatment, and now we've come in at $475,000, look how much we've saved you already. That's not a savings. But so what is our frame of reference? Often the studies in academia or done by industry or others that show savings in healthcare are savings versus optimal care. If we paid every therapy for every patient at any price, and then how much would this cost versus that? So, but we don't deliver optimal care. What would our healthcare system be like if everybody paid cash for all of their healthcare today? For drugs, for physician office visits. We wouldn't have as much access. We wouldn't have the same system. Our system has enabled new innovative drugs. It's enabled many types of access. But I'm worried about the abuses at what used to be the fringes, and the fringes are closing in.
Thank you, Dr. Schondelmeyer. Thank you very much to our panel. I appreciate it very much. You've been patient with us, and this has been an excellent discussion for us to try to go deeper into the weeds and understand what types of options and what types of choices and thoughts we need to have in the future. Thank you again, Mr. Smith and Dr. Schondelmeyer. I appreciate it very much. Thank you.
Thank you, Mr. Chairman. Thank you.
Our next presenter will come from what we like to regard as our innovative corner. We will be hearing from Mr. Bill Hanley and Ms. Sue Schettle regarding the convenings, and this does harken back to honoring choices. The issue here is we had indicated that we would indeed explore end-of-life services. And this is what we're going to discuss briefly today. We've had robust discussions on pharmaceuticals twice now, and I think the questions that the Senate panel offered were excellent. So having said that, if the presenters could come to the podium and introduce yourselves and begin, that would be excellent. Thank you very much, and thank you for joining us.
Great. Thank you, Mr. Chair, Senators. My name is Bill Hanley. I am not a medical industry person. I'm a media guy, and I was with TPT for many, many years. 37 years, I led the team that created Almanac, which was 1,000 years ago. It was about 6 or 7 years ago that I had what I thought was a really unusual experience that I now know many Minnesotans and many people in this room have had. My father, who was down at Fairmont at the time, called me and said, you know, your mom, who was 92 at the time, has been diagnosed by the wonderful people at Mayo with end-stage renal failure. And so they're beginning to talk to us about dialysis. And I said, well, Dad, what's the problem? What are you worried about? He said, she doesn't want dialysis. She doesn't want that care. She's 92, she's got other things going on, and we've talked about it, and we're sort of at a loss, because the medical people are pushing appropriately, but pushing very hard for her to start this care, and she doesn't want it. And that began for my family, my sisters and my kids and all of us, a conversation led by the wonderful people at Honoring Choices, Minnesota, that you're going to hear from soon. A conversation, a family conversation about what are the choices that my parents wanted to make about the end of their life and the care that they had. And talking to my parents about the fact that they really could make those choices. And they could ask the medical community to honor those choices, even though it wasn't what the medical community wanted them to do. And my mom eventually did decide to skip dialysis. She got the kind of death that she really wanted. My father, at 95, felt very good about the process, that he was able to give her the kind of death that she wanted. And all of us, including my children, felt really good that we've been able to participate in the process and know for certain that that's what my mother had wanted. Now flash forward to a couple of years ago, and my friends at Honoring Choices approached me, and our friend Kathy Wurzer from Minnesota Public Radio, who was doing a project on end of life, called me and said, you know, we really want to figure out a different way to talk to the people of Minnesota about the importance of having family conversations about end of life before you get to the bedside, so that you could really, our loved ones could speak for themselves. How do we put together a collaboration, a partnership of people that can begin a statewide campaign to talk about end-of-life care and how a family can have that conversation? And so we began a project called the Convenings, again, 2 years ago, a fantastic, I mean, really a fantastic collaboration amongst the CEOs of Health Partners and Alina and CentraCare, and then media organizations and faith organizations, media including Care 11 and our old friends at TPT. And so I want to show just a brief clip of something that aired on Care 11 this last year, and then talk a little bit about what the Convenings is.
Messages can be broadcast in waves.
Coming up here in Morning Edition, world, national, regional news.
They can also be carried in conversation.
We talk about it here a lot.
The conversation in Ely these days isn't what you'd expect.
Estate planning, end of life. End of life. Planning.
Yes, death is on the table.
Because we're all old. We're old. Yeah.
And because the conversation came to them.
Kathy Wurzer was up in town with her book that she wrote with Bruce Kramer.
I'm Kathy Wurzer. More to come here on Morning Edition from NPR News.
Kathy Wurzer started broadcasting her conversations with Bruce Kramer on NPR in 2011, shortly after he was diagnosed with ALS.
It was a life-changing experience.
An experience Bruce described as living while dying.
Bruce was actively dying, and I was with him at the end, and he said, I want you to look for the ripples in our work. And I said, I have no idea what you're talking about. What are the ripples? And he said, You'll know it when you see it.
Ripples are how interviews turn into a book,
Thank you. Thanks for being here.
and a book turns into the Convenings.
Everybody has a story. Everybody.
The Convenings are a community formed for end-of-life discussion, and they're here because they ripple.
So a year ago, my mother died.
Through Dr. Joe Bianco.
It was a wonderful thing.
Wonderful, because through his mother's death from Parkinson's, Dr. Joe learned the power of care directives and communication.
So when she died, we knew exactly what she wanted. It drew us closer. Just having the conversation was important.
And Dr. Joe turned to Kathy to bring that conversation to Ely.
I'm going to give you 5 minutes. Talk to your neighbors, unless you are Finnish or Norwegian, and then you're going to stare at your shoes, and I know that.
I haven't ever done any advanced care directive yet, but I'm going to.
It's a promise many put in writing.
It's a commitment card. I'm not asking for your firstborn child or anything like that.
I think it's real important that your loved ones know what to expect.
8:28 here on Morning Edition.
Kathy says that love is where this whole wave started.
I remember I was talking to Bruce, and he said, the Beatles were right. All you need is love.
What really has the deepest meaning of all is the love that I share.
So the Convenings is a series of live events which we've done in communities from Ely to Laverne to Coon Rapids and beyond, and some media work, again, to essentially begin to normalize this conversation about death and dying, and the fact that as patients we have choices that we get to make. My parents didn't really realize they got to make those choices. And the organization that is so central to this whole activity from the very beginning, 10 years ago, is the Twin Cities Medical Society and their CEO, Sue Schettle, and the Project Honoring Choices, which I just can't say enough about. And so with that, Sue Schettle.
Thank you. Thank you for having me. My name is Sue Schettle. I'm the CEO of the Twin Cities Medical Society and the co-founder of Honoring Choices and co-founder, actually, of the Convenings as well. I'm just going to talk a little bit about the project that we've been working on, as Bill said, for about a decade, called Honoring Choices Minnesota. Dr. Kephart will speak after me. He's our medical director, so I'm glad to have him here with me today. You know, our mission is to make advanced care planning the community's collaborative standard of care. So we're trying to normalize the conversation related to end of life so that it just becomes just part of who we are as a community. It's not about filling out forms. Oftentimes people say, oh, you're the people that want to have people fill out forms. It's more than that, much more than that. Of course, as a medical industry, we want to have that form in the electronic medical record, and we want to have that accessible. But what we're really trying to do is encourage people to have family conversations around the kitchen table. And I'll just start with a few facts, some of which you've talked about earlier in other testimonies, but you know, we know that people aren't dying where they want to die. You know, some reports say 7 out of 10 people say that they want to die at home, yet 15% actually do. There's a big disconnect there. 70% of people actually die in hospitals, long-term care facilities, and nursing homes. You know, we spend a lot in healthcare, as you all know, over 20% nationally, and I think at 32% in Minnesota is what I've seen. And then we know, too, that 28% of the total Medicare spending in the last 6 months of life is, for Medicare, is very high, and it's $170 billion from what I found. So we know hospice is underutilized, palliative care and geriatricians we don't have enough of. So as the medical society, our physician group got together and said, what can we do that would make a difference? And we landed on, we can do a better job around end of life. And so we started that journey about 10 years ago, and TPT was a great partner with us as we started that work. I'll just tell you briefly how we're structured, and I do have some handouts that hopefully you have in front of you there. But the Twin Cities Medical Society serves as the convener. We're the coordinator, we're the catalyst, we're sort of the home of Honoring Choices. But it really is a statewide initiative with statewide partners, including everyone that you think would care about end-of-life care. So nursing home, healthcare, you know, AARP, people that come from all of those sectors. But we really have 3 main areas of focus, and so we work in the community. We have a lot of ambassadors and volunteers that work in the community to to talk about end-of-life care in a culturally sensitive manner, whether it's in a mosque or whether it's in a senior community center, wherever. We have a large presence there. We also have a great presence within the healthcare sector. As a medical society, we're connected to the healthcare systems, and so we have, Ken will go into it a little bit here, but we have a fair amount of people, we have a lot of people trained, and we have a lot of things going on within healthcare. And then health and human services. So there's 3 different sectors that we look at: community, healthcare, and then health and human services. And so I know that we want to have allow a lot of time for questions from you. So I think I'll stop my presentation there and let Ken talk a little bit about some of our outcomes.
Thank you. So I'm Ken Kephart. I'm a physician, family doc. I've been on your chair for a long time. Good to see you again.
Thank you.
So I got to admit, you guys are amazing. I mean, I kind of have interest in a lot of the topics you were talking about. I had a hard time paying attention the whole way, and you guys have done an amazing job. I'm glad you're still with us, talking to us. But anyway, so I think the main point I want to make is that we've been active, we've had support in the health systems. They spent a lot of resources inside their systems and supported us to help normalizing the conversation. And it is about conversations that patients can have with their family members or trusted loved ones, so that when the time comes to make a decision, and the really important number I stress to people is, here's the deal. Most of us would like to die quietly in our sleep without any kind of disability or illness at the end of life. That'll happen to about 20% of us. The rest of the 80% of us will die slowly over the last several years with increasing disability, and about half the time you're going to be too sick for us to ask you directly what you want. That's why this is an important thing. You need to have somebody else that can step in, make decisions that you would want made, knows what you would want, and doesn't have to carry that guilt around the rest of their life. So I think that's really just the kernel of what we are about. The healthcare systems have done a pretty good job, but they can improve on trying to capture what the goals of care are and recording it in a place where it can be found. But the one thing the healthcare systems can do, which is what I want you to understand, is the direct-to-community work for people who aren't really connected to the healthcare system. They're not touched until they have a major event, and then they're inside the hospital in a crisis, and it is very difficult to have a meaningful conversation about decisions when the patient can't participate in a crisis with a family member, not only doesn't know what they might want, but a lot of times it has an inherent distrust of the hospital and the system because they're not part of it, they're not comfortable with it. So one of the things we're doing that nobody else can do is go out into the communities, connect with the leaders in the community, whatever community we're talking about, whether it's a disadvantaged community, recent immigrants, refugees. We've done a lot of stuff by creating videos in 3 different languages to help bring this information so that discussions can happen in a place where people are comfortable. So it's not the first time they hear about this when they're in a crisis inside the hospital. So I think we're doing a lot of good work. Still a lot of work to do. And I think I'll stop there and answer questions.
Thank you very much to all of our presenters, and I would take just a moment to share a story that when I was a senior medical student, Dr. Kephart was my intern at Ramsey Hospital on the burn unit and the surgical unit, and we talked late into the night about the philosophy of medicine, so welcome. Are there any questions or comments from the senators at this point? Seeing none yet, I will go ahead and start. I would like to first share a comment. I think the intersection that you provided us on the Honoring Choices handout that has got a sort of a garden growing under a brightly lit yellow sun does a wonderful job. What I so appreciate is, as a family doc who does indeed deal with death and dying each and every day, I appreciated that it's about the conversation. I'm afraid that so many times when we have organized efforts moving forward, it's about a checklist. And so once someone's done some quasi-advanced directive, whether it's a POLST form or whatever, they check it off and said, good, I got that done. And 5 years later, I'm asking, I don't have a living will in your chart. Did you do one? Oh, yeah, we did one. And I said, do you know where it is? No, but we did one. And I think that gets to the point that it's really about the conversation. And if you want to be transformative in our society, that conversation can be transformative, but filling out a piece of paper, signing the bottom of it is not going to transform. And when I had breakfast with you this morning, Bill, you mentioned that what you're trying to do is, within a generation's time, change the way our society approaches end of life. We've got a lot of scary terms and phrases out there now. When we start to talk about this, oftentimes phrases like death panels and things like that will intrude on the conversation and keep us from what we're trying to do. So I very much appreciated that. Also, I would do the unusual thing for me, because I'm somewhat of a skeptic when it comes to some of the government interventions that have the best of intentions. But the advanced care planning initiative that Medicare has put into place over the last year in terms of actually compensating physicians and providers to have the discussion regarding advanced care planning. I read an article the other day that they've more than doubled what they thought would happen in terms of the conversations around our country. I think they had expected, I can't remember if it was 300,000 or if it was, I can't remember what the number was, but it more than doubled. And I think that this is just the perfect time as we have this perfect storm of crisis with costs and things like that. So thank you very much for your work. Dr. Kephart, you have a comment to make.
Chairman, if I could just, not only does just filling out a form and putting it next to your will and safe deposit box where nobody can find it doesn't help, but having even a single conversation is inadequate unless you're going to need to use it in the next year or so. So part of the learnings is that it's a process of regular reviewing, because people do change their minds as they experience different diseases. So what they may say they want at 65 may be much different than what they want at 85. And so it's much, it's kind of like you think it's not that complicated, and every time you get deeper into it, you realize how important it is to have a process around this. And so it's having conversations and regular retouches to make sure that's still what you want, or maybe the person you picked as a healthcare agent is no longer living, or maybe they've got a cognitive impairment, or you're not married with that same person. So there's a big process around this to make it relevant. Because the one thing we really can't predict very well is when you're going to die. Just that everybody will face it at some point.
Thank you, Dr. Kephart. And I think it was a lot easier to predict when someone would die 100 years ago, when the top 3 causes were pneumonia, followed by dehydration, followed by tuberculosis. But those 3 causes of death are no longer on the top 10 radar screen, really. Today it's heart disease, cancer, stroke, and oftentimes those are elongated processes. We're a committee trying to address the bending of the cost curve downwards. End-of-life cares, in some studies, indicate that 40 to 45% of dollars are spent in people in their last year of life. Were you king or a queen for a day and you had our job in front of you, where would you look to specifically go to try to bend the cost curve down, yet doing a better job than what we may have done in the past with the resources we have?
I think the meat, and this is what's happening, I think a lot of our healthcare systems around the Twin Cities and the state right now is when somebody becomes seriously ill, their goals of care need to be talked about directly, and predictable things like dialysis or pacemakers or ICU care need to be addressed in a timely way. And I think if that's done at the right time, the biggest thing around that's prevented, I think, good discussions has been our hesitancy as clinicians to put prognosis into the picture. So they don't want to remove hope. But study after study show that patients do, for the most part, want the truth, want your best description of their care, of their status, and want to have time to have discussions with their family members about goals of care. If that's done meaningfully, there is some pretty good evidence that the value you bring to somebody at the end of life is much higher, and you'll probably save a dime. I mean, it's a pretty good value-based proposition to really increase the value of the patient's experience and the family's experience at the end of life, and probably save it's much, I think, more meaningful for patient and family to be at home in the last month of life than in an ICU, and a lot less expensive.
Dr. Kephart, approximately 10 years ago, Aetna, I believe, changed their insurance parameters regarding hospice. And they removed the necessity or requirement that patients had to sign off that they would not avail themselves of potentially curative therapies. And they also expanded the predicted lifespan from 6 months to 12 months. Those two things had the potential to drastically increase the usage of hospice. And in fact, that did occur with Aetna. And what they found overall was they were bending the cost curve downwards. Right. Do you think, or do you have any ideas on how we might take that lesson we learned from Aetna's behavior and put that into Minnesota public programs or in Minnesota insurance carriers, and how would we do that?
Well, I think the hospice benefit certainly can be looked at. That's probably more of a federal CMS issue, but they are looking at it and trying to decide if that how to blend palliative care and hospice in a more meaningful way so people can have goals of care, palliative care discussions earlier. I think that fortunately there are some actual payment changes that Medicare has done, which we want to make sure the rest of the insurances follow, because not only do they have the advanced care planning charge that's available now for never used to be, they also have several new charges this year for paying for prolonged discussions with family members instead of having to have the patient face-to-face when the patient's too sick or cognitively impaired. So they're paying for things they never used to that can help support having these discussions. And I would put it under the goals of care, palliative care, and not necessarily just hospice, to help people have a little smoother glide path toward the end of their life. And I think the one thing I will say that you probably don't want to hear, because I'm not sure it's bending your cost curve or the state's cost curve, but I do think there needs to be some address of the medical assistance payments, which are so low. There's so much cost shifting. There has to be some way to try to make that quite so steep. I mean, they're clearly under the cost of actually providing care. And so, you know, something like some states pair it with Medicare or something like that. So there's not so much, so it's more transparent.
Thank you, Dr. Kephart. Senator Klein.
Mr. Chair, no question. I just have a comment for the group. And thank you so much for your work in, I would say, changing the culture of medicine. When I went through medical training in the 90s, on our hospital services, a death was really considered a failure, a treatment failure, and a failure on the part of the team. It was emotionally and academically approached in that way. You play that out to the final analysis, of course, you have a 100% failure rate, and it's been much more edifying to realize that all of our patients will pass on. And you talk about how individuals and families maybe don't want to have these discussions, and I can tell you, physicians at a time did not either, but it's become part of our duty to sort of address that and make those tough transitions happen for the benefit of the patient in an ethical and a meaningful way. And I think your leadership in starting those conversations has been essential. Thank you.
Yeah, Mr. Chair, I have neglected as one of my things I was supposed to do. We do have activities with the medical school and the nursing schools around doing a better job of preparing the clinical side of it to have these conversations. So that's part of what we're doing also.
Thank you very much, Dr. Kephart. And Mr. Bill Hanley and I did talk this morning about other possible ways of, if you will, penetrating our society with these kinds of conversations. Obviously, we could try to get it into the business world, but even trying to approach this into our universities and our higher education centers, that would be another area. And in those kinds of initiatives, oftentimes the legislature does play a role, although that would not be part of the purview of this specific committee per se. So having said that, did you have a closing comment, ma'am? Yeah, if you would, Ms. Schettle will make a closing comment. Thank you.
I just have one request, and that is that currently when you renew your driver's license, you are asked if you have a health care directive. And right now, we are unable to get that data. I don't know that it's being captured. And that, I think, would help us. It's just one benchmark, but it would be able to help us to show that we are making a difference, at least in that sector, that people are reporting. We could probably go back and capture data for a number of years. But I think if there's, that's a small thing, but if we could get some help from you in that regard, I think that would be helpful. And thank you so much for having us here today. The Honoring Choices program has been, as I said, we're starting our 10th year, and it's actually serving as a national model. It's being implemented in 12 other states, and Minnesota's a national leader. We didn't intend to be doing this, I think, as long as we are, but here we are. So thank you for having us.
Well, thank you again, and I have asked Andrea, our committee administrator, to follow up on your specific requests so that we can forward that to the appropriate committee over the next couple of months in preparation for the 2018 session.
Thank you.
So, thank you very much. Thank you, presenters. Appreciate it. Are there any other questions or comments from the committee? Otherwise, we will adjourn. And right now, our next scheduled meeting is October 12th. 2017 at 1 o'clock. Thank you very much. The meeting is adjourned.